Good morning. Assalamu alaikum from Abu Dhabi. My name is Rajai Namas. I'm a consultant rheumatologist at the Cleveland Clinic, Abu Dhabi. First, I would like to thank the organizing committee for this fascinating agenda and program. They really made an excellent job. And so today, over the next 20 minutes, we have an eminent speaker, Dr. Farida Balushi, who is well known in the region. She is a senior consultant rheumatologist and internal medicine at Royal Hospital, Oman. She introduced the ultrasound joint examination and rheumatology unit, being the first rheumatologist in Oman who's trained in this field, and she has multiple publications in the fields of rheumatology. And Dr. Farida today will share very fascinating data about JAK selectivity impact on the management, a very interesting topic that I think most of us like to hear about. And this session is recorded, and at the end of the session, we have 5 to 10 minutes for questions. So please feel free to put all the questions in the chat box. And without further ado, I will we can start the presentation of Dr. Farida. Thank you.
Good morning. Thank you, Dr. Rajai, for the nice introduction. And thank you all for joining us today in this symposium by AbbVie. Actually really delighted to be talking to you about Upadacitinib. I'll walk you through the different trials and clinical programs that were conducted in order to assess the efficacy and safety of Upadacitinib and different rheumatological indications, whether it's in rheumatoid arthritis, psoriatic arthritis, or an ankylosing spondylitis. This is my disclaimer. And our story, which is Upadacitinib story, is number 3, because now we have it fortunately approved and 3 indications as the clinical programs was conducted for in rheumatoid arthritis and psoriatic arthritis and in ankylosing spondylitis. We talk about unmet needs in rheumatology, and we have always heard about unmet needs in rheumatoid arthritis specifically and other inflammatory arthritis. And in fact, when we go into the history of the biologics and when anti-TNF blockers were introduced in the market, we were very happy, we were thrilled. We were feeling that this is the answer for all our patients' problems. We give anti-TNF blocker and the patient is back to normal. And while it was really effective and actually magical for a large group of patients with rheumatoid arthritis, there was still a group of patients who were not responding at all. Still, they were not able to be effective members in the society. They were debilitated by their symptoms. And when IL-6 inhibitors came to the market, we were thrilled again. And we were like, okay, now we have option A. If it fails, we will go to option B, and that's that. That answers all the patients' needs and ends their misery again. And unfortunately, again, this was not the answer for all of our patients. We still have a good number of patients not responding. And then we have another option and another option and another option. And while more options were helpful for a specific group, we still have, up until now, with all what is saturated in the market, we have patients that are not responding to any of the options. And we came to the realization that for rheumatoid arthritis, there is never enough for our patients. And just like diabetes, just like hypertension, the more options we have, the better the outcome. So it helps a larger group of our rheumatoid arthritis patients. And when we talk about ankylosing spondylitis or psoriatic arthritis, the problem is even bigger because the options we have are even smaller. And the diversity of the patients with spondyloarthritis is much more than rheumatoid arthritis, which makes it even more difficult to target. If we look into the data, what are the different studies showed about, the improvement, the number of patients responding to TNF or IL-6 or whatever? Most of the studies shows that 60% of patients improve. But there are 40%, which is slightly just less than half of our patients who are not responding to any of the options. And this is basically just focusing on the remission criteria, which is important for us as rheumatologists. But what about our patients? Our patients care about symptoms. And residual pain, stiffness, and fatigue continues to be a problem for our patients, even for those who have achieved low disease activity or the target remission criteria. In addition to that, we have patients who are unable to take the injections due to a reason or another. If you look at surveys, we have a lot of surveys now, questionnaires published internationally, showing that 50% to 60% of patients prefer oral therapy. And so we need more oral options for this group of patients. And then last but not least, of course, our friend and our enemy, methotrexate. The need to use methotrexate for a large group of biologic therapy makes it a less favorable option for many of those patients. because they cannot tolerate methotrexate. Whatever we ask them to do, the way they take it is probably different. We go to subcutaneous injections instead of oral injections, but still GI intolerance, hepatotoxicity, and probably pulmonary toxicity continues to be a problem, limiting the use of methotrexate. And currently we have only tocilizumab and tofacitinib that can be used as monotherapy. And of course, this is an area of unmet needs, and we need more options in that regard. So let's move to spondyloarthritis. I know you are all familiar that spondyloarthritis is not just one entity. It's a group of disorders that include psoriatic arthritis, ankylosing spondylitis, and so many other. So it comes with a diverse clinical manifestations and domains, from spinal involvement to peripheral joints. We have dactylitis, enthesitis, IBD, uveitis, psoriasis, and nail psoriasis. And as you see in the percentage, the percentage of patients affected and different spondyloarthritis are so large that if we need to target the improvement in symptoms in general, our patients, we need to target all these domains, which is not an easy process, and we cannot ask the patient to take multiple medications to target each point of those. And so the therapies that are used in psoriatic arthritis or spondyloarthritis in general has to target all of these different domains effectively. And this is what we are going to talk about when we talk about select programs for upadacitinib. So what are the approved options currently for these three diseases? And GCC countries, you see in the bottom, the circle for rheumatoid arthritis, we have definitely much more options than for psoriatic arthritis and AS. We have the JAKs and we have the T-cell co-stimulators, of course, the TNFs and the IL-6 inhibitors. But for psoriatic arthritis, the options are a little bit less, with IL-12 and 23 and IL-23 inhibitors with phosphodiesterase inhibitors. And for ankylosing spondylitis, the options are really much less. TNF, JAK inhibitor, and IL-17, exicuzumab and secukinumab. So more than a third of our patients will not respond to these medications. So upadacitinib is just offering another option for this group of patients. And of course, we need more therapies for ankylosing spondylitis. And this is an area where more research has to be focused and more options have to be developed. So let's go over how JAK inhibitors work. In order to understand that, we need to understand what happens on the cell surface. We have the cytokine. The cytokine binds to the receptor, and it allows the transphosphorylation and activation of JAKs. So look at the JAKs here in the picture. Once JAKs are activated, they move toward the bottom of the receptor, which is called the receptor tail. They phosphorylate the receptor tail. Once the receptor tail is phosphorylated, the STAT protein, which is available inside the cell, it will move to the receptor tail, and it will get activated. Once the STAT protein is activated, it moves inside the nucleus, and it will lead to activation of gene transcription. Gene transcription is very important for the formation of cytokines and different interleukins. And it is the main way where the cytokines are produced and the inflammatory process starts. So when we start JAK inhibitor, we block the phosphorylation cascade. All this phosphorylation that takes place will be inhibited, which means the cytokine production will be reduced, which in turn lead to downstream of the inflammation. And there are many cytokines that are targeted by the JAK pathway. There are some red color directly mediated by the JAK inhibitors. And in the blue color, you see those that are indirectly mediated by the JAK inhibitors. So once these are inhibited, it will lead to a reduction of the cytokines, which leads subsequently to less inflammation, whether it's in the nails, joints, skin, bowel, gut, and so on. So let's go over the upadacitinib clinical programs. We have 5 clinical programs that were conducted for rheumatoid arthritis, 2 for psoriatic arthritis, and 1 for ankylosing spondylitis. And if you look at the right side of the screen, for rheumatoid arthritis, we have a large number of patients being studied in different backgrounds. Some of them were methotrexate naive, some of them with methotrexate inadequate response, some of them with biologic inadequate response. Not only that, some of them we're comparing upadacitinib with methotrexate, and in Select Compare, they were comparing methotrexate with upadacitinib as combination therapy, as opposed to adalimumab as an active comparator with methotrexate. So for rheumatoid arthritis part, I'll be focusing on Select Compare because there is an active comparator. We all need to know how does it perform comparing to adalimumab. And also, if you look at the size of the patients, including in this trial, is around 1,600 patients, which is a large number of patients. So what did that show? There are the ACR50 that was mainly looked at as a primary endpoint, and upadacitinib was statistically superior to placebo. There are higher percentage of patients achieving remission as defined by ACR50, which is around 45%, as opposed to only 15% in the placebo arm. The same applies to the pain and the HAQ score. If you compare adalimumab with upadacitinib, you see that the upadacitinib arm was not inferior to adalimumab, which is very reassuring. We all have a lot of experience with adalimumab, and it's reassuring to know that we have at least equally effective treatment option for our patients. So what about sustainability of these results? If you look at this graph, it's very interesting because it shows you the response in terms of DAS 28 remission criteria from week 0 until 156 weeks. The green represents the upadacitinib, whereas the purple shows you the adalimumab. And you see that the results are comparable, although the numbers looks more in favor of upadacitinib compared to adalimumab, but this study was not designed to show superiority of adalimumab. For the orange is the placebo. Of course, the placebo had to be stopped at week 26, and patient had to be started on active medication since they were not responding to the methotrexate monotherapy. This is another secondary endpoint in the Select Compare. This is the remission for DAS, CDAI, SDAI, and Boolean score. The green again here represents adalimumab. The green represents upadacitinib, and it shows across the board that there are statistically higher percentage of patients achieving remission with upadacitinib compared to adalimumab, and this was statistically significant. So we have data statistically significant showing some higher percentage of response in the UPA compared to adalimumab. So now I'm sure the data that we are representing in the Compare trial can be applied to Select Mono and monotherapy RA patients and the biologic inadequate responders as well. More or less all of them showed good efficacy of upadacitinib across the board. And so you can go through all these trials that will be able to represent a larger group of patients that you see in your clinics. Let's move now to psoriatic arthritis. We have basically 2 trials for psoriatic arthritis. We have Select PSA1 and Select PSA2. I'll be referring to them by PSA1 and PSA2 for the sake of the presentation. So PSA1 studied patients who had inadequate response to DMARDs, but they were biologic naive. And these patients were started on either upadacitinib or adalimumab as an active comparator. And the PSA2 trials, it was just upadacitinib. It was not compared with adalimumab, but it included patients who had inadequate response to biologic therapy. And the number of patients is large, especially for PSA1 is 1,700 patients, and PSA2, 600 patients were studied, which is quite impressive. So let's look at the data. What did it show? The primary endpoint was ACR20. And this slide shows you the proportion of patients that achieved ACR20 in the upadacitinib arm, which is in yellow, is significantly higher than a placebo, which is in gray. And the numbers for both upadacitinib and adalimumab was comparable, whether if you compare ACR20 or ACR50 or ACR70. So the results of PSA1 was very impressive. And then of PSA2 in the graph shown next to the one I just discussed, it shows the proportion of patients achieving remission in PSA2, which are those patients who failed previously other biologics. And of course, you will expect lower number of patients in those who have failed biologic compared to those who are biologic naive, because, as all the studies and our clinical experience show that once one DMARD has failed, the chance of failing another biologic DMARD is higher with subsequent trials, even with different mode of actions. And this graph actually shows you the sustainability of the results that we have shown. So whether ACR20 again, 50 or 70, whatever results are achieved at week 12 are sustained at week 24 and again at week 56. And these numbers, clearly shows you the superiority of the upadacitinib in yellow compared to placebo, which is represented in gray. What about the skin? It's very important for us as rheumatologists to target not just the musculoskeletal manifestations, but the skin manifestations of psoriatic arthritis. And these results are reassuring. And I would like to just let you know here that the upadacitinib was not studied in psoriasis per se. There are no approval for psoriasis per se because no studies was conducted for that matter. However, the PASI score that was assessed rigorously and this trial confirmed that there is significant response as far as the skin is concerned. So PASI 75 response was achieved in 63% of patients with upadacitinib as opposed to only 21% in a placebo. And this is a very good number. And even if you go higher with PASI 90 and 100, there are still favorable outcomes. And these results were sustained up to 56 weeks. So we come to enthesitis, which is for me is the most difficult, and I'm sure most of us struggle usually to control and resolve the enthesitis in patients with psoriatic arthritis. And usually the results are frustrating for the other options that we currently have. But if you look at the graph here, the first graph, it shows you that 50% had complete resolution of their enthesitis by week 24, compared to only 32% in the placebo arm. And for dactylitis, the second graph, again, there is almost 80% response compared to 40% in a placebo. And last here, but not least, the axial symptoms. So do a patient with psoriatic arthritis and axial involvement respond to upadacitinib or not? This data shows that BASDAI 50, ASDAS were all showing significantly higher a proportion of patients achieving the remission as compared to placebo, and reaching something between 50 to 60%. So having said that, now we know as a conclusion that upadacitinib is effective for psoriatic arthritis, whether we are talking about the peripheral joint involvement, the skin involvement, the axial involvement, enthesitis, dactylitis, across the board. Upadacitinib was showing very promising results in psoriatic arthritis. Now let's focus about ankylosing spondylitis. There is only one study conducted in AS, and it only included a patient who had inadequate response to more than 2 NSAIDs, and there is no active comparator. It's only upadacitinib versus a placebo, which is usually NSAIDs, of course. And the sample size was around 187 patients. So what did it show? Again, there was a very good response as far as the ASAS-40 response is considered. At week 14, we see that 52% of patients achieved the response criteria in the upadacitinib arm, compared to only 26% in a placebo, which means twice as many patients had improvement in the upadacitinib arm compared to placebo. So what about the other remission criteria, or the scoring system used in spondyloarthritis? We have the BASDAI here, showing exactly same results. Twice more patients achieved BASDAI improvement in upadacitinib compared to a placebo. And this graph shows you the decline in CRP, which of course represent decline in inflammatory burden in patients. So the mean change from baseline was continuously improving from the start of upadacitinib up to the end of the trial at 64 weeks. And as I was talking to you about previously, that what patients care about is the pain rather than whether the remission is achieved or not based on different scoring system. And this is where we looked at the total back pain, nocturnal back pain, and peripheral pain, and all the graph revealing very beautifully the response in the yellow, showing decline in the pain over time, which is sustained up to 64 weeks. And this is the last part for the selective program in ankylosing spondylitis. It shows that the radiographic progression was significantly lower in patients receiving upadacitinib comparing to placebo. Mind you that this data is only up to 2 years. And of course, for radiographic progression, usually you need a longer period, which was, of course, something that we will be able to assess in a future extension of the selective program. But so far, these results are reassuring, showing us that probably our patients, if started in upadacitinib, are less likely to have radiographic damage compared to a placebo, which is NSAIDs. And this takes me to the conclusion of the selective program efficacy. Now, we know it's effective. I'm sure I convinced you that upadacitinib is effective in RA, PSA, and psoriatic arthritis. But what about safety? I know it's a very hot topic about the safety of JAK inhibitors in general for our rheumatology patients, especially when it comes to thromboembolic diseases and probably malignancy, major cardiovascular events. This was all looked at in the selective program with extension oral surveillance also conducted by AbbVie. And it shows no red signal there at all when it comes to serious infections, malignancies, major cardiovascular events, or thromboembolic event, except for herpes zoster. This is something we all know, that herpes zoster is more common in JAK inhibitors than in other mode of actions or other biologics. But if you compare here the tables, one of them for psoriatic arthritis, the first, and then to ankylosing spondylitis, and then in rheumatoid arthritis, across the board, the data for psoriatic and ankylosing spondylitis are similar to RA population. So there is no difference in the safety, whatever was the indication. And this is an interesting slide. It shows you the long-term safety profile. We are talking here, rheumatoid arthritis, it was studied in around 4.5 years, and psoriatic arthritis, 3 years, and in ankylosing spondylitis, 2 years. The first graph shows you the serious infection rate compared to adalimumab. You see the green is upadacitinib, and you don't see any signal there. for worsening in upadacitinib, or worsening, I mean serious infection. And again, the same applies to opportunistic infection. For herpes zoster, it clearly shows in the green part that upadacitinib has higher risk of herpes zoster reactivation compared to adalimumab. For major cardiovascular events and for thromboembolic events, data are very similar, almost identical to other biologics in this trial. So in summary, the safety profile of upadacitinib was established in more than 6,000 patients in 8 major trials conducted. Whether we are talking about AS, PSA, or rheumatoid arthritis, we know that there are no new significant safety signals. In particular, what we are concerned about, no higher risk of thromboembolic events, no higher risks of serious infections and opportunistic infections or malignancy compared to other comparative arms, which is adalimumab. Except for herpes zoster, of course, we know herpes zoster risk is higher, and this is confirmed in this trial. And eventually, we will need extensions of the selective program, and we need the registry to tell us more about long-term safety. But for now, I think the data that are shown here tells us clearly that upadacitinib is safe, upadacitinib is effective, and upadacitinib will be a great option for our patient with different rheumatological diseases. And with that, I would like to conclude my presentation. Thank you.
So thank you, Dr. Farida, for this fascinating lecture. It was really very clear and very comprehensive. So far, we don't have any questions. So you clearly showed that there is still unmet needs in rheumatoid arthritis, which I think all of us agree that we still need more medications. You clearly showed the efficacy of Rinvoq, and as it's important to have a quick or robust medication, we always look for sustainability, which you clearly showed among different disease, AS, PSA, and RA. And you clearly showed the benefit among different disease activity scores, even the stringent ones. You showed the improvement in PROs, and there's improvement in radiographic data, especially in rheumatoid arthritis. And most interestingly, that you showed comparison to the standard of care, which is Humira that we all use. It's the most prescribed anti-TNF, that it was superior at certain points, especially in rheumatoid arthritis. And you highlighted the importance of safety. I think we have an excellent experience over the last 10 years with JAKs. So I think we don't have any questions. So let's ask a question. I know that safety profile is different from a region to a region, and sometimes we read, international trials, and when we apply to our local patients, we see a different, especially with safety. So from your experience in Oman with JAKs, how do you see the safety of JAKs in general among your patients in your experience?
I'm sorry, Dr. Rajai, I lost you there due to the,
yeah.
I think.
So my question is that when we apply international data to our local patients, sometimes we see differences, especially with safety. Sometimes we know that geographically there's a difference in safety profile. From your experience with JAKs overall, how do you see the safety in the Omani or the Gulf patients that you have? Can you share with us, please?
Sure. First, I'd like to invite everyone to attend the abstract that we are going to present. One of my colleagues is going to present about tofacitinib use in Omani populations, and it's a good number of patients included in this study. I can briefly tell you about the safety data there. We did not have any alarming signals, and it was over 2 to 3 years period, the study. We have not had any patient with thromboembolic diseases directly related to JAK inhibitors, particularly Tofacitinib. However, I had only one patient who had COVID, and she's an elderly. Previously, we used to give patients above 60 Tofacitinib. It was commonly used among that age group, although that is not something I would do now. But she had COVID, and when she developed that, she had a stroke. And so the question was whether COVID caused the stroke or was it caused by Tofacitinib. And of course, we stopped Tofacitinib because we had other options to treat the patients with. And we think it's more COVID related. So this is one thromboembolic diseases among the large number of patients that we had, almost 60 to 70 patients, sorry, not 90 patients that we studied. In addition to that, we had one patient who developed ovarian cancer 6 months into Tofacitinib. So again, is it linked to Tofacitinib? I don't think so. It might be a coincidence. And recently I had a patient who developed thyroid cancer, papillary thyroid cancer, that was around, again, 9 months into therapy. It wasn't a long duration. So I wondered whether this is, again, related to it or not. Either ways, we decided to stop Tofacitinib in these particular patients. When it comes to major cardiovascular events, I have not had any problems with patients developing any cardiac event, whether major or otherwise. Infections, herpes, for example, I don't have a single patient with JAKs with herpes. But again, if you compare our population to other population like Japan, for example, you will see more herpes there anyway. I see more herpes with mycophenolate mofetil, for example, than I see it with any other treatments that I give to my patients generally, and other indications as well. So Tofacitinib related herpes, no experience, nothing at all. The only problems I had and I encountered in a good number of patients is infections, cutaneous infections, persistent abscesses, but this is only very, less than 5 patients that had that. Generally speaking, JAK inhibitors were very effective in our experience, and they were very safe. Even the hyperlipidemia and the very well-known side effects that can happen, we don't see it frequently at all in our population. A disclaimer, I don't have any patients on upadacitinib yet, so we'd like to hear from you probably in regarding to experience.
Yeah, so thank you very much. Yeah, so we have around 200 patients that were exposed to JAKs over the last 5 years. 60% of them were on Tofacitinib, and the rest split it between Olumiant and Rinvoq. Over the last 5 years, we had 3 cases that had monodermatomal shingles, zoster. 2 of them, they stopped the medication for a week or 10 days. They took, Valtrex, and then we resumed the medication. One of them refused to go back because it was involving the genital area. We have no DVTs or any major cardiovascular events over the last 5 years. Infections, I think it's comparable to biologics. I have one patient that developed acne, and that what made her facial acne, and that, facial and involving the chest, and that made her also stop the medication. From a malignancy standpoint, I actually have 2 patients that have thyroid cancer, biopsy proven, and they have thyroidectomy, and with agreement with a hematologist and the endocrinologist, we agreed after 3 years from being in remission to resume the medication. She was on it initially, and then I think these are the main side effects of interest that we share. But zoster, I think, is very low as with prednisone and Celsep than what I see in rheumatoid arthritis. And I think recently there was a recent publication about methotrexate and the risk of DVTs. I don't know if all of us read it. It was just recently published in November of last year by Dr. Smolin. And there's a 2 times risk of developing DVT with methotrexate in a large population of more than 50,000 patients. They did a propensity score analysis from a US Medicare cohort. They looked into methotrexate and hydroxychloroquine. There was a 2 times risk of DVTs in patients more than 65, and with a high hazard ratio. So this raises that we are dealing with a very high risk medications. But I think the FDA in 2010 highlighted the safety signals that all of us were aware. And I think this is a good thing that we stratify our patients. And we have good experience with methotrexate over the years. We know that at one time we were scared about liver toxicity. Now we give it with full confidence. We stratify patients. Then came biologics, and again there was a risk of infection, malignancy, ILD, heart failure, and again we gained a good experience, and now we are more confident to give our patients. And I think we are learning more with JAKs. And I think most of us as rheumatologists, we have this wise decisions that we stratify patients before starting any medication. So I think highlighting a signal is good for safety issues.
I just want to ask telling us about, was it compared to?
Yeah, I'll share it with you. It's in the Seminars of Arthritis and Rheumatism by Dr. Daniel Solman. It's a very nice paper.
Yeah, but the lupus itself increases the risk of chronic disease.
Decisions that stratify patients. I think there's a voice. What's that, Dr. Farida? You have a question?
Yeah.
Yeah, I'll share it with you. It's in the Seminars of Arthritis and Rheumatism by Dr.
Increases the risk of talk about it later, me and you. But any other question?
Yeah. Do we have more time? I think we can end the session. Again, thanks for all the colleagues that we're hoping to meet. We'll have more conferences coming, so we'll meet inshallah in a good health, and God bless everyone inshallah. Thank you, Dr. Farida.
Very much. Thanks.
Thank you.
Good morning, colleagues. Welcome to second day of our conference. We do have an exciting program for you, both in adult rheumatology and pediatrics. They are running parallel all day today until later on in the evening. We hope that you can join as many of those sessions as you can. Thank you very much and have a nice day.
Good morning, colleagues from the GCC and all over the world. Today, we'd like to welcome you to our second GCC Rheumatology Conference in its second day. Today, we'll start our adult rheumatology program with interesting sets of lectures as well as research sessions. The first lecture is going to be on cardiovascular aspects of rheumatoid arthritis, and the second lecture will cover local guidelines from Saudi Arabia in the management of rheumatoid arthritis. And then we'll move on to a research session in rheumatoid arthritis where colleagues from all over the Gulf will present their research orally. The next exciting session would be on spondyloarthritis and psoriatic arthritis. This session is going to start with a lecture on updates of spondyloarthritis in the Gulf, current and future vision, and then will be followed by a research session in spondyloarthritis and psoriatic arthritis. And then we'll move on to the highlight session of this rheumatology conference and would be on postgraduate medical education in rheumatology. This session will start with a keynote lecture on postgraduate medical education and current and future trends, and then will be followed by colleagues from all over the GCC presenting their postgraduate rheumatology programs. And lastly, we're going to end up the day with an interesting session on challenging cases in adult rheumatology from all over the GCC. In this session, we'll highlight the presentation of those cases as well the management plan. I hope you enjoy the second day of the conference, and I hope a lot of learning from this conference in the second day, and be looking forward to see you tomorrow for further more exciting sessions.
Good morning, everybody, and welcome for the first sessions in adult rheumatology. We have the first topic about the cardiovascular aspect of rheumatoid arthritis, and Dr. Suad Al-Hannawi is going to present this topic. Dr. Suad is a well-known figure. She is a consultant of rheumatology in Emirates Health Service in Dubai, and she is associated assistant professor on the Medical College of Sharjah University. She is involved in different committees, as she's a chairman of the Research Ethics Committee in Dubai Medical District of the Ministry of Health and Prevention. She's a deputy chairman of Central Research Ethics Committee of the Ministry of Health and Prevention. She's the head of Rheumatology Committee of the Ministry of Health and Preventive in UAE. She's a chief of Clinical Evaluation Committee for the Rheumatology Specialty. And she's the president and founder of the GCC Gulf Cooperation Council Association of Immunology and Rheumatology. She is also as examiner in the Royal College of Physicians of UK and Ireland, as well as the Medical College of Sharjah Hospital. Welcome, Dr. Suad.
And good morning to all of you. Welcome in the second GCC Rheumatology Conference, Oman version, and thank you very much for having me. I'll be talking about one of my favorite topics in rheumatology, cardiovascular rheumatoid arthritis. I have nothing to declare. The objectives of this presentation will be talking about cardiovascular risk, rheumatoid arthritis, and why rheumatoid arthritis patients are at a higher risk of cardiovascular disease. Then we'll talk about the traditional cardiovascular risk factors, rheumatoid arthritis, followed by talking about non-traditional cardiovascular risk factors in RA. Then briefly, we'll talk about vascular screening test for subclinical cardiovascular disease and what are the EULAR recommendations for cardiovascular management. So the first part is cardiovascular disease in RA and why they are at a higher risk. Rheumatoid arthritis patients have been found to be at a greater risk of getting cardiovascular disease and atherosclerosis. RA patients tend to have 5 to 10 year reduction in lifespan compared to their age and sex matched controls. Cardiovascular disease account for about 40 to 50% of death in rheumatoid arthritis. With cardiovascular disease the top, the cerebrovascular disease come as a second cause of mortality. So we can see that the first cause of mortality, which is cardiovascular disease, and the second cause of mortality, which is the cerebrovascular disease, both are atherosclerotic diseases in nature. It's not only the mortality, but even the morbidity. Cardiovascular disease is the top comorbid disease associated with rheumatoid arthritis. So why RA patients tend to have high risk of cardiovascular disease as a morbidity and as a mortality? The nature of the disease by itself have been found to contribute to the risk of developing cardiovascular disease or atherosclerosis. For example, those who are rheumatoid factor positive have been found to be at a higher risk of getting cardiovascular disease, with rheumatoid factor associated with cardiovascular mortality even in early RA patients. And when we say in early RA patients, we mean those who present with less than 6 months of symptoms onset. As well, rheumatoid factor have been found to be associated with overall mortality in established RA. And not only rheumatoid arthritis patients, but even in general population. We know about 10% of general population might have positive rheumatoid factor. Those who have positive rheumatoid factor tend to have more cardiovascular disease than general population with negative rheumatoid factor. And of course, we know that rheumatoid factor is associated with more severe rheumatoid arthritis and more level of inflammation. As well, anti-CCP have been reported as independent cardiovascular risk factor, and it can predict the onset of or the development of ischemic heart disease. As well, rheumatoid arthritis patients tend to have more of traditional cardiovascular risk factors, like RA. Patients tend to have more dyslipidemia, they have more hypertension, they have more hemostatic changes, they have high insulin level or hyperinsulinemia, as well as smoking might contribute to the risk and a lifestyle of RA patients. And when we say traditional cardiovascular risk factors, actually the term traditional is a term used by the American Heart Association to define or to refer to a classical cardiovascular risk factors. Although there is a number of traditional cardiovascular risk factors which have been reported to occur in rheumatoid arthritis more than in non-RA patients, yet traditional cardiovascular risk factors have been found to be insufficient to explain the excess cardiovascular risk in RA. So there is a role as well for non-traditional cardiovascular risk factors, like, for example, homocysteine level and uric acid. And most importantly, inflammation, which have been found to be an independent cardiovascular risk factor. Inflammation play an important role in the onset, progression, and complication of atherosclerosis. And atherosclerosis by itself is now defined as an inflammatory disease or inflammatory condition. So let's talk in more detail about traditional cardiovascular risk factors of rheumatoid arthritis. Dyslipidemia. Dyslipidemia is very well-known risk factors for cardiovascular diseases. And when we say dyslipidemia, clearly we don't mean only hyperlipidemia, because hyperlipidemia is only one of the dyslipidemic pattern or changes that might occur in rheumatoid arthritis patients. RA patients tend to have low total cholesterol, which might sound good, but the low total cholesterol is mainly driven by low HDL. The HDL, as we know, is anti-atherogenic. So if there is low HDL, that means there is a high chance of getting atherosclerosis. And not only that, the HDL within the inflammatory environment associated with rheumatoid arthritis tend to lose their protective effect. So the HDL is no more a benign lipid. It changed to a dangerous lipid. Similarly, we have in most of RA patients low LDL. And low LDL, again, sound as a good thing. But actually, within the inflammatory environment of RA, the LDL becomes smaller in size and more dense. So we'll be having more small, dense LDL. This small, dense LDL is highly pro-atherogenic, and it's consumed by macrophages to produce fatty streaks within the atherosclerotic plaques. As well, patients with RA tend to have high triglyceride level, and this is the first, let's say, dyslipidemic change that might improve once we control the inflammation. And they tend to have as well high VLDL, which is triglyceride-rich lipid. Hypertension is another traditional cardiovascular risk factor reported in rheumatoid arthritis patients. RA patients tend to have high systolic blood pressure and a tendency to have high diastolic blood pressure. Hypertension and rheumatoid arthritis have been found to strongly correlate to the level of inflammation, particularly to the level of interleukin-6. Smoking. Smoking is well known as a risk factor for development of cardiovascular disease or for development of atherosclerosis. And it's not like it's a cardiovascular risk factor only, but smoking as well have been found to be associated with more seropositivity of rheumatoid arthritis. And previously, I stated that seropositive RA patients or a positive rheumatoid factor, they are at a higher risk of developing cardiovascular disease. As well, smoking is associated with more radiographic progression and damage in RA and more chance of developing rheumatoid nodules. It's been reported that high CRP at first presentation of rheumatoid arthritis patients to a rheumatologist is significantly associated with history of smoking. And it's not only current smoking, but ever smoked as well is a risk factor for developing high CRP, which means high inflammation with an odd ratio of 5.6. If smoking duration is more than 10 years, the odd ratio increased to 7. Sedentary lifestyle might contribute to cardiovascular risk in RA, although we don't have any study to prove that sedentary lifestyle is associated with cardiovascular disease or rheumatoid arthritis patients, but as per the definition of the American Heart Association, 30 minutes walk 3 to 4 times a week is important to reduce the cardiovascular risk. Thinking about RA patients who have synovitis, joint pain, and fatigue and tiredness, majority won't be able to perform 30 minutes walk 3 to 4 times a week. And this might contribute to cardiovascular development in RA. Hyperinsulinemia is another cardiovascular risk factor in RA patients. Basal hyperinsulinemia and insulin resistance have been reported for rheumatoid arthritis patients, and both abnormalities have been found to be strongly correlated to the degree of inflammation. Interestingly, steroid, which theoretically will increase insulin resistance, have been found in RA patients. If we treat the patients with a steroid, the insulin resistance will improve, and that contributed to a suppression of level of inflammation. Similarly, the same findings have been reported with the use of sulfasalazine. Then we have the hemostatic changes. There are a number of hemostatic changes occur in rheumatoid arthritis patients, and I won't go into the details of that because of the time of the presentation. So after the traditional cardiovascular risk factors, let's discuss non-traditional cardiovascular risk factors of rheumatoid arthritis patients. Homocysteine. Homocysteine is one of the non-traditional cardiovascular risks in RA. Homocysteine promotes the oxidative stress and oxidative changes, and the oxidative changes or the oxidative environment is pro-atherogenic. As well, homocysteine have been found to activate the pro-inflammatory factors like many of the chemoattractant factors, and it will facilitate the binding of monocytes to the endothelial cells, which is the first step in the development of atherosclerosis. As well, it impairs the plasminogen activator binding to its endothelial cell receptor, and it will increase the proliferation of smooth muscle cells, and all that lead to a progression and development of atherosclerosis. Similarly, homocysteine interfere with the production of nitric oxide by the endothelial cells because of the injury that homocysteine will cause to the endothelial cells. Uric acid is another independent cardiovascular risk factor. Apart from knowing that serum uric acid is usually associated with a cluster of other cardiovascular risk factors, like, for example, obesity, high blood pressure, high lipid, glucose intolerance, renal disease, uric acid by itself have been found to contribute to cardiovascular disease by reducing the production of nitric oxide and causing endothelial dysfunction. As well, uric acid contributes to the level of inflammation, and it's like a vicious cycle. Uric acid will lead to more inflammation, and inflammation will lead to having more abnormal uric acid. Similarly, uric acid will cause some of the oxidative changes, and it will affect the renin-angiotensin system, which will increase the high blood pressure in RA patients. Then we have inflammation. Inflammation is really important because inflammation have been found to be a major element in atherosclerosis onset, progression, and complication. As I stated, atherosclerosis by definition now is an inflammatory condition. And if we look at the steps of atherosclerosis and how atherosclerotic plaques will develop and build in any cardiovascular disease or in any atherosclerotic disease, every single step in the development of atherosclerotic plaques is contributed strongly to inflammation and to inflammatory markers and many of the tumor necrosis factor and chemoattractant protein and inflammatory markers, such as C-reactive protein. C-reactive protein, we know that it's produced in the liver by interleukin-6 as a main factor for the increase in the level of CRP. CRP is not only produced in the liver, but it had been found to be produced or to increase its expression in the atherosclerotic plaque. CRP has a direct role in the development of atherosclerosis, and this is why it had been established as an independent cardiovascular risk factor. High CRP can predict the onset of cardiovascular disease and the recurrence of MI. CRP contribute to atherosclerosis by activating many complements and by increasing the expression of the adhesions molecules and the binding of monocytes to endothelial cells, which I stated that it's a first step in atherosclerotic plaque development. As well, it mediates the LDL uptake by macrophages, and this would lead to a production or to the formation of fatty streaks. C-reactive protein as well decrease the nitric oxide synthase expression, and it can cause a direct injury as well to endothelial cells. So, knowing that cardiovascular disease is common in rheumatoid arthritis patients, how we can detect atherosclerosis is there is any chance of detecting atherosclerotic problems in patients with rheumatoid arthritis. So, we'll talk briefly about vascular screening test for subclinical cardiovascular disease. There are a number of screening that can be done, but we won't go through the details of all of that because simply they are mainly for research purposes. But what had been mentioned by the American Heart Association in their guideline that it can be used for screening for presence of subclinical cardiovascular disease is carotid intima media thickness. The carotid intima media thickness measurements by an ultrasound started in 1980 when number of studies have been conducted using carotid intima medial thickness, and it's been reported that this technique is feasible, reliable, valid, and cost-effective, and it can be used in clinical trials as well as on clinical practice. And it can help to tell which patients might develop cardiovascular disease. So it's like a surrogate markers for cardiovascular disease development. When we look at carotid intima media thickness, it's simple procedure. You just need to put a probe on the neck of the patient while the patient is extending his neck and looking to the other side, just to go 1 centimeter below the carotid bifurcation and to measure the intima media thickness, which is the area with a small arrow in the picture. The thicker the intima media thickness, the more the chance that the patient is having subclinical atherosclerosis. And there are some papers now which state that we can measure the same layer within the coronary arteries because atherosclerosis is a generalized or it's a general like sorts of changes that occur in all the vessels in the body. So it might occur in coronary artery even before it occurs in the carotid arteries. But because of the difficulty of assessing the intima thickness within the coronary arteries, the most feasible and easy way to do it is to look at the carotid intima media thickness. Knowing that patients with rheumatoid arthritis are at a higher risk of developing cardiovascular disease, the EULAR recommendation came for cardiovascular risk management, which have been released in 2016. They came with 10 recommendations. Just briefly, I'll go through the recommendations of EULAR for managing cardiovascular disease in RA patients. This recommendation is applied as well for ankylosing spondylitis and for psoriatic arthritis. They are all inflammatory conditions associated with high C-reactive protein. And it's really important to know that in psoriatic arthritis patients, those who are at a higher risk of developing cardiovascular disease are patients of psoriatic arthritis who have high C-reactive protein. While those who doesn't have high C-reactive protein, so they don't have high inflammation, they are usually not at a higher risk of developing cardiovascular disease, which again proves that inflammation is the main factor in atherosclerosis and in the onset and development of atherosclerosis among RA patients. And this is why the recommendation came out stating that it's really important that we should control all the cardiovascular risks in all RA patients, similarly AS and PSA. So if the patient is having high blood pressure, that need to be looked after and controlled. If they have hyperlipidemia or any other cardiovascular risk factor, we need to pay attention to that. And we should assess the patient for the presence of cardiovascular disease. And that should be done at the beginning of or the onset of the disease. It should be repeated every 5 years, or if there is like a major change in the treatment that you use for suppressing the inflammation or to control rheumatoid arthritis patients. As well, this EULAR recommendation emphasized as well that we should follow the national guidelines to assess patients with RA for presence of cardiovascular disease. In the GCC, unfortunately, we don't have any national guidelines to assess, to help us to assess patients with cardiovascular disease, so we can follow the national guidelines. If there is any lipid change, that's, as I stated, it needs to be controlled. As well, the prediction model, if it's to be used, it has to be multiplied by 1.5 like multiplication factor for rheumatoid arthritis patients, because they are really at a higher risk. As well, they recommended in this recommendation that we can use the looking for the atherosclerotic plaques, and that simply is by carotid intima media thickness. They emphasized on lifestyle change and healthy diet and exercise, as well as to stop smoking. And there is something really important I'd like to mention here. If the patient are at a flare-up or at an active disease, better not to assess the lipid profile. You have to wait for some time, because, as I stated, with high inflammation, the dyslipidemia will occur, particularly the high triglyceride level. Once you control the inflammation, the lipid changes might improve by suppressing the inflammation, and it will give you a better insight about what kind of dyslipidemia that your patient have and how to control it. In the EULAR recommendation as well, they recommended not to use NSAID much, and if you are going to use it, this should be like within a careful approach, as well as if you are going to use a prednisolone, should be to lower possible dose and to a shortest possible duration. I think I came to the end of my presentation. Just as a conclusion, I want to emphasize that rheumatoid arthritis patients are at greater risk of cardiovascular disease compared to general population. Inflammation has an important role, or elementary role in the atherosclerotic process. Non-invasive ultrasound screening can be used to detect subclinical cardiovascular disease. And it's really important to control cardiovascular risk in patients with RA to reduce the morbidity and the mortality of atherosclerosis or cardiovascular disease in RA. Thank you very much.
Thank you very much, Dr. Suad. Now we have the second speaker, is Dr. Hanan Reis. She presented yesterday as well, and she was introduced at that time. She's a senior consultant rheumatology and lupus. She's a deputy director of medicine department. She's a director and fellowship of rheumatology program. And she's a clinical rheumatology and lupus fellowship from the University of Toronto. She's also a founder of Saudi Arthritis Registry and a member of the American College of Rheumatology. She is going to present to us the Saudi guidelines for the management of rheumatoid arthritis. Welcome, Dr. Hanan.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman, for a nice introduction. Bismillah ar-Rahman ar-Rahim wa salatu wa salam ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. First of all, I would like to thank the organizing committee for the second GCC for inviting me to talk about very important topic, which is the recommendation for treatment of rheumatoid arthritis in Saudi Arabia. Our outline for this lecture is to talk about the Saudi pathway for diagnosis and management of rheumatoid arthritis, which was published in 2020. And we'll talk in the second part about the development of 2021 American College of Rheumatology guideline in Saudi Arabia. You know the importance of have a local guideline in a country. Especially in a country like Saudi Arabia, where we have more than 35 million, and we have sometimes different lifestyle, different genetics, and different sort of centers managing a patient with this chronic illness. And we know that the prevalence of rheumatoid arthritis is common in Saudi Arabia, and one study is around 1 in 1,000. So having a national guideline and recommendation is essential to make the management of these patients equal in all cities, especially in area where we have no rheumatologist. So it will help our general physician as well as our junior rheumatologist to follow the important pathway for management of these patients and to prevent the morbidity and mortality that can occur if patient not managed in the right way. And as you know, that the ideal way to have a de novo guideline. However, having a de novo guidelines is time requirement, and it needs a lot of resources, a lot of meta-analysis and systematic review. And the time it ranges based on the international guideline and even the national, between minimum of 12 months for mild or small guidelines, and for huge topics, it reaches up to 2 years or sometimes 3 years to have full data for required for publishing a guideline. And it's costly, and the cost range from $300 in small guideline to it might reach even $1 million in some of the guidelines. So adoption of high certainty guideline is better and quick and easy. And the recommendation, we know it's an evidence-based. However, it might be inappropriate in the context of local and might miss recent or relevant evidence. So when we start organizing the pathway for diagnosis and management of RA, it was in 2019. We have the idea to have a local pathway. At that time, we have the American College of Rheumatology which is the standard for most of rheumatologists, and it was in 2015. And at that time, we have a lot of medication in the available, but it's not there in the guideline. So we have at the same time the EULAR guideline, which is 2018, which have good coverage of some of these medication. So we thought that our pathway will be from these two international guidelines, the American College of Rheumatology and the EULAR. And our team was of 8 senior rheumatologists. After finishing this pathway, it was reviewed by another 4 senior rheumatologists, and we have a supervisor methodologist with us. And this pathways was reviewed by the Council of Cooperation Health Insurance, as well as by the Council of Health Association, and it was under the Saudi Commission of Health Specialists and Saudi Society for Rheumatologists. We use the ADAPT process, and it's a modified 5 steps of development, which is developed by Christensen et al. Include planning the project, then initial assessment of recommendation, and if needed or new data need to be modified based on the new data, we modify it, and then we did the publication and evaluation. Our main objectives from that pathway, number 1 is early rheumatoid arthritis diagnosis and referral, because from our data and from the registry, we found that there is variation in the referral. The major city where there is a tertiary centers and a good health system with primary and secondary health hospitals, we have the referral within almost 6 to 12 months. And when we compare it to the other from the periphery, it's much less. And we will have a publication recent about this referral. Also, we have publication referral from our colleague in the Western region, and they found again there is a delay of almost 1 to 2 years of patient. And this delay affects the management and the important step of early treatment and treat to target in this patient. So we concentrate on the early RA diagnosis and referral pathway, and then we have management, medication management, as well as management of comorbidities and vaccine and so on. So we use the treat to target strategy. We insist in our pathway that all rheumatologists should follow specific measure when they see their patient, and to have an aim of remission and if not low disease activity. And we have clear table how to diagnose, how to refer, and if it is early arthritis, how to manage, what to do, what investigation you have to do, and how to follow these patients. I will not go to the details, but it was there in the website of the Saudi Society of Rheumatology. We concentrate on the core of treatment, which is methotrexate, how to treat, when to treat, and when to start biological or targeted therapy. And in our recommendation, if patient failed methotrexate, it will be increased to maximum and then shifted to subcutaneous. If not, we can introduce either biologic or targeted therapy according to the patient criteria and comorbidity. And if third step, if patient on biologic or targeted therapy and failed, then he can go to phase 3 and to choose based on whether he's seropositive, seronegative, and the reason for failure, and so on. So again, it was a clear table for our rheumatologists and for our fellows to be followed. Also, we concentrate on the treatment of RA patient with comorbidity, and we have a detailed pathway for each important comorbidity, like congestive heart failure, treatment in patient with skin cancer, patient with lymphoproliferative disorder. We know that in our country, hepatitis C, hepatitis B is common, so we have also detailed the pathway for management of patient with hepatitis B and C. and a special pathway for those with recurrent infection and patients with solid malignancy. We concentrate also about the importance of vaccination of all patients with early and established RA, and we have to vaccinate them prior starting any therapy. And recently also we add, if patient above 50, give vaccine for herpes zoster and yearly flu vaccine. And again, in the pathway, if the patient already in therapy, we determine how to give the vaccine, when to stop the medication, and when to resume the medication, and so on. At the end of this pathway, we have different case scenario to help our junior colleague to choose the best therapy for the patient in a nice scenario way. Now, in the next maybe 7 minutes, I will talk about the recommendation for treatment of rheumatoid arthritis, which is the development of 2021 American College of Rheumatology guidelines. So here now we have a recent guideline. So we find that it's better to have adoption of this guideline. It will help a lot in the distribution in all sectors. And we contacted the American College of Rheumatology for approval of use their guideline, and we have the acceptance. So we select the 2021 ACR guideline for treatment of rheumatoid arthritis as a source of guideline for Saudi Arabia. We know that the ACR guideline follow standard methodology, which is generation, which is the BICO question, and we use the same population, intervention, comparator, and outcomes, the selection of critical outcome, and the systemic literature review. And I will talk about this one because during adoption, we did, for the specific point, we did further systematic review and the conflict of interest in the management. This is the guideline. And as I mentioned, our objective is to adapt a set of prioritized recommendations from this 2021 ACR guideline for the treatment of rheumatoid arthritis. And the adaptation builds on the published guideline to increase the efficiency while accounting for a local context, and to ensure the applicability and increase the subsequent uptake by our rheumatologists for this guideline. So instead of using different guidelines available in the literature, we wish that our local rheumatologists to use this Saudi adaptation guideline. The working group for this adaptation, the supervisor and coordination for the panelist is me, and with co-chair with Dr. Mohammed Imer, and the guideline panel are 19 members representing the following stakeholder groups. We are 15 rheumatologists from Ministry of Health, from the military hospitals, from National Guard, from the private hospitals, as well as the university. We have one clinical pharmacist, we have one patient representative, we have 2 policy makers from the Ministry of Health. And actually, we did several workshops for the adaptation process, and as well as all of the guideline meeting was online because of the COVID-19. We have 3 methodologists, Prof. Eli Al-Haqil from University of Beirut, and 2 colleagues from the same university. We have 2 international experts, the chair of the source guideline, Dr. Liana Frankel, and the chair of 2015 guideline, Dr. Singh. The method that we use, that same BICO question, so the targeted population is our RA patient, and we adapted the recommendation consists of general rheumatoid arthritis patient population, as I mentioned, and the main target audience for this guideline is the rheumatologists in Saudi Arabia and their patients with rheumatoid arthritis. and the pharmacist, the policymaker, and individual of charge of coverage decision in both private and public sectors. We followed the grading recommendation assessment, the development of evaluation, grade development methodology, and the right adaptation checklist for reporting adapted guidelines. For each recommendation, we developed decision based on evidence on health effect from the source guideline, updated using newly published studies identified by the panelists, as well as contextual information. For the adaptation, as I mentioned, we use the grade development combined with advantage of adoption, and the de novo guideline development, and is based on three cornerstones: the identification of credible and relevant existing guideline, developing grade evidence-based table for each of the recommendations, deciding on adoption and adaptation or de novo development of each of these recommendations. For reporting these guidelines, we followed the recently published Right to Adapt checklist for reporting adapting guideline in breast. And these are the grade development we are following. So the grade development is 8 main steps. So setting groups and rules, and this is number 1. Then we are doing prioritization guideline topics, because we, after made a training to our colleagues, then we ask them to do prioritization for each question of the guideline. And as you know, that we have a 44 question. And after that, we choose the prioritizing questions for guideline, because some of these guidelines we adopted as it is, and based on the rheumatologist review of this prioritization, we select the main question that is chosen by these 15 rheumatologists. Each one alone, they choose their prioritization question, and we took the most question chosen by all rheumatologists in charge. We did updating systematic review, identifying local data for these specific questions. We are preparing the grade table and through the methodologist team, and the training the guideline panelists, and formulating and rating strengths of the recommendation, and collecting the feedback through the methodologist with us. So as I mentioned, we used the evidence systematic collected in 2021, and it was presented to us by the methodologist, and then even by the panelists. And we reviewed the evidence, and we discussed any additional factors, and we reassessed the direction and the strength of the recommendation. So the panelists rated the priority of each of the, as I mentioned, of original ACR recommendation, based on whether this recommended intervention differ in the case A context from the USA context in terms of feasibility, accessibility, resource use, and the impact of equity, as well as the current practice in Saudi Arabia. So the key question, we used a structured and standardized process for the prioritization recommendation from the ACR guideline, and the coordination group asked the panelists to rate the priority of each of the original ACR recommendation based on whether the recommendation intervention differ in Saudi Arabia from the USA context in these items that I have mentioned. So we solicited the panelists to share any newly published relevant data to this prioritized question. The two methodologists with us assessed the eligibility of these studies in duplicate and independently. And for the studies judged eligibility, the methodologist abstract data and assessed risk of bias in duplicate were chosen accordingly. And for the importance of the outcome, we adopted the source guideline rating the disease activity as a critical outcome, and the physical function, radiographic progression, quality of life, as well as the adverse event as important outcomes in this selection. The evidence synthesis for patient value and preference, we relied on the systematic review already available on the topic used by the source guideline, the ACR, and the KSA panel adopted the result of the review following a discussion with the patient representative. And for the cost of the data, the panel relied on the cost data collected from the National Unified Pro Company, which is NOPCO, which is the standard here in Saudi Arabia for the price of this medication. And for the remaining of the contextual factors, there was no systematic collection of information, and the panel relied on their own experience. So for each question, the coordinating group developed a grading table, used Grade Pro software, which include both information on the health effect from the evidence report, as well as from the contextual information. In the preparation for the panel meeting, we did invite the panel member to review this evidence data and the comment on the included information and vote on different ATD criteria and recommendation. The decision-making process during the panel meeting, we use the ATD in the grading as a platform to facilitate the decision-making process, and the panel voted on each of these evidence data criteria, then voted on direction and strength of the recommendation. Then the methodologists used this voting as a starting point for discussion, but also to reach the final decision if it could not be reached in the consensus. So suppose that we reach to 50-50 consensus in such specific data, then we discuss each one till we reach to the consensus that we need. So we know that the ACR guideline have major topics, and 44 recommendations, 7 of them were strong and 37 conditional. After doing this prioritization, we come up with top 5 questions that need adoption. And these are the questions that raised for recommendation, which is the initiation of treatment of DMARD-naive patient with low disease activity, whether to initiate sulfasalazine or methotrexate. And the second question, initiation of treatment in DMARD patient with low disease activity, whether to start hydroxychloroquine, conditional to the other DMARD. The third question, initiation of corticosteroid without short term. Initiation of DMARD, conventional DMARD without short term, because this is a recommendation from the ACR, and then we discuss this point, whether to have short-term steroid or not. And for patients taking oral methotrexate who are not at target, a switch to subcutaneous methotrexate is conditional by the ACR. Then we discuss this question. And the last question was for patients who are taking methotrexate plus biological or targeted DMARD who wish to discontinue the DMARD gradually, whether to use the same recommendation of the ACR or to have our own KSA regarding this point. So this is an example of the initiation of the question. Patients with low disease activity, whether to start hydroxychloroquine or sulfasalazine or methotrexate. Then we discuss it in different aspects for each medication compared to the other. We based on the data available, with the cost of the Saudi Arabia, and the patient preference here, and we follow different way of looking to this data with a strong or conditional recommendation, and the strength of recommendation we are following, as I mentioned, the desirable effect of the medication, undesirable effect. And in each point we have this panelist opinion, the certainty of the evidence, the value of the evidence, the balance of the effect, the resource required, the equity, accessibility of the medication in different centers, in the private, in the local, in different cities, and so on, and the feasibility again of this medication. So the extent of to which we can be confident that the desirable effect of an intervention outweighs the undesirable effect, we choose it. So the strength of recommendation can have one of two strengths, either strong, the panel is confident that the desirable effect of adherence to such a recommendation outweigh the undesirable effect, or vice versa, and the conditional that the panel conclude that the desirable effect of the adherence to the recommendation probably overweight the undesirable effect, and vice versa. And here, the example for question that we chose, and we went through everything regarding this point that we discuss it, and in each point, so some of the questions took in each meeting we took like one question, and some of the meeting we managed to have 2 questions. We have total of 3 meetings after a total of 2 workshop of training. So this is the way, and this is the table how it was, and how the way that we discuss it with all team or all panelists available, and with the methodologist. And then we come, and you can see here we discuss the cost and the other patient preference and the availability, feasibility, and so on. At the end of each question, we have summary of judgment in a table like this one, and then we come up with the recommendation, the case A recommendation for this specific prioritization question. And here an example of one of the question, how it reach. So when we have like in this question 3, we reach a conditional recommendation for the intervention. And in this question was about the steroid and short-term steroid in patient with moderate to severe RA at the start of therapy. I will not talk about all of these questions because we are still working on it. And see you, inshallah, in the 8th Saudi Society of Rheumatology Conference between 9 and 12 of March in Al-Madinah Al-Munawwara. All of you are welcome. And Dr. Muhammad Amir, inshallah, he will present this case A adoption question and recommendation. So be with us in Al-Madinah and see you there. Thank you again, and I'm willing for any question. Thank you.
Okay, thank you, all the both speakers. You have excellent presentations. We have in the chat here 2 questions. The first one for Dr. Suad seems what immunosuppressive drugs have proven to show strongest evidence, if any, to reduce cardiovascular risk, in your opinion? Is there any particular drug or just to control the inflammation, whatever available medication?
Okay, if we are going to take it from the evidence-based, it's going to be methotrexate. Methotrexate have been reported to reduce mortality by 70%, rheumatoid arthritis patients, and the main reduction for reducing mortality was because of suppression or reducing the chance of getting cardiovascular disease. We do have some evidence as well to support the biological treatment, but they are not strong evidence, like we'll be having contradicting results for each single biological medication. Similarly with the prednisolone, although I mentioned that some studies showed that prednisolone reduced the cardiovascular mortality, but then the EULAR recommendation came to say that if we use prednisolone more than 10 milligram, we are increasing the risk. If it is less than 10 milligram, then probably we can reduce the risk by suppressing the inflammation. But when it comes to methotrexate, there is no doubt that it suppresses or it's reduced the chance of getting cardiovascular disease, a reduction of mortality by 70%.
Okay, thank you. The second question is for Dr. Hanan, maybe, even though not related to the guidelines. They said the immunosuppressive drugs have proven to show, what is the duration between the diagnosis of cancer and to start the biologic which need to be taken?
It depends,
Solid cancers.
Yeah, so it depends. If it is solid cancer, according to the recommendation, once treated, they can start the therapy. straightforward.
When it came to remission.
Yeah. But it depends.
Oh.
Immunosuppressant with methotrexate, you can start it while he is on treatment. I mean, there is no contraindication. You treat it like non-malignant.
Okay. Okay, thank you. Regarding the guidelines for Dr. Hanan, as already clear the guidelines there, are you going to apply it as because of the shortage of maybe rheumatologists and those patients in the rural areas, difficult to approach rheumatologists? Are you going to make it as a virtual clinic from those rural areas and try to manage them as early as possible with providing medication in those areas in Saudi Arabia?
It depends. Now the good news that we have more than 350 rheumatologists, and now we have rheumatologists in all regions, which is good. But still, some rural area they have no clinic, and they usually refer to the nearest center to them. Having said treatment virtually totally is difficult. To start with the first diagnosis and to be sure from the diagnosis, you want to see the patient and examine him and to see the lab and so on. After that, maybe if he's stable, virtual. And actually, we have some visiting rheumatologists to this area. And through the society, we have a plan of such a thing in an area where we have no rheumatologists. I mean, to visit once they prepare the patient and see. It was done before through the Ministry of Health, but it's not on a regular basis. So we plan such a thing, inshallah, in the coming year.
Okay. For Dr. Suad, you have mentioned about the screening, just ultrasound, carotid ultrasound. Is there any other modalities just to do it every 5 years? You said at least every 5 years to be screened.
There are some other modalities, but they are not recommended by the cardiovascular societies. When it comes to carotid intermediate thickness, it had been mentioned in the American Heart Association guideline for screening of cardiovascular disease, as well as it's there in the EULAR recommendation. If you go into the details of the recommendation, it had been mentioned clearly that we can use the carotid intermediate thickness. But definitely when we talk about screening, it's not only the ultrasound, it's as well to screen them by proper history, to get whether they are hypertensive or not, to control that, to look at the dyslipidemia they have, to control the hyperlipidemia if it is not can be corrected by correcting the inflammation or by suppressing the inflammation. But if you want to focus on the vascular screening, yes, there are endothelial screening, to look for the endothelial function, radial tonometry, and many others, but they are mainly for the research purpose. And none have been included as a recommendation apart from carotid intermediate thickness. The carotid intermediate thickness, I stated, it's very feasible, reliable, and non-invasive. It can be done very quickly. It will take less than 5 minutes to be done if you have a proper sonographer or a rheumatologist who knows how to do it.
Okay, that's why you said the lipid level is not reliable, especially in those active inflammatory stages. Do you think starting the statin from the beginning, does it play a role in these cases as a primary preventions?
No, you should wait before you use a statin. Should not first of all look at lipid profile during active disease. If you are if you are going to screen your patient while he's let's say during flare-up or active disease, you should not decide about whether to start anti-lipidemic agents at that time. You have to repeat it once they are in remission. And if it is still high while they are in remission, then there is a role for statin. And there are some studies which showed that using statin to reduce the hyperlipidemia in patients with rheumatoid arthritis help in hindering the progression of carotid intermediate thickness and reducing the cardiovascular risk. But when the inflammation is active or it's high, there are some dyslipidemic changes which might improve once you control the inflammation, particularly the triglyceride level. It's the first to drop down once the inflammation comes down.
Yeah, the questions also came here. Who should screen those patients? Either a rheumatologist in the clinic, it's a VC rheumatology clinic, or by family doctors or by cardiologists? Who's supposed to do these things?
It is the responsibility of the rheumatologist, and he can collaborate with the cardiologist colleagues, but he is a rheumatoid arthritis patient, so he's our patient. We should screen for that. Like proper history should be done from our side. Proper investigations should be done from our side. Ultrasound can help, but it's not like mandatory. It can help. But if for example, the rheumatologist doesn't know how to do the ultrasound for carotid intima media thickness, it's not really that important. But proper history and proper investigations is really important. In my clinic, all the rheumatoid arthritis patients are seen by our colleagues, cardiologists, but that not because it is our regular practice, but because of the research purposes, but we are benefiting from that. Like every rheumatoid arthritis patient is seen by our consultant cardiologist as well for further screening. After, of course, I do the basics and then I refer them for a cardiologist for further assessment.
Thank you very much. I think the time is over, and I would like to thank both of you for excellent presentations, and see you.
Yeah, one thing, just I want to thank you all and to invite you to our conference in Medina. And inshallah, we will have the guideline presented by Dr. Mohammed Amer about the final guideline. So I just presented the methodology. So welcome in Medina Munawwara next month.
Thank you very much.
Thank you very much for all of you, and thank you for having me.
Yeah. Good morning, everybody. We are going to the second session today about rheumatoid arthritis, and this is about rheumatoid arthritis and research. It's my pleasure to introduce the first speaker. He's going to talk about the relationship between serum level of homocysteine, leptin, and neopterin and disease activity in rheumatoid arthritis patient with or without extra-articular manifestation. The speaker is Dr. Yasser Al-Gazar. He's MD Rheumatology, and he's a lecturer of rheumatology and Faculty of Medicine in Al-Azhar University. He's a consultant adult rheumatology at Al-Madinah National Hospital in Medina Al-Munawwara, and he's a member of Saudi Society of Rheumatology. Welcome, Dr. Yasser.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome for all. First of all, I'd like to thank the scientific committee for inviting me and accepting my abstract to be presented in this GCC conference. Hoping the next year, inshallah, will be face-to-face. My talk will be about the relationship between the serum level of homocysteine, leptin, and the neopterin and disease activity in rheumatoid arthritis patients with or without extra-articular manifestations. Rheumatoid arthritis is a chronic inflammatory disease characterized by chronic erosive arthritis, mainly involves the peripheral joints. Comorbidities is the major issue in this disorder, and the cardiovascular disease has been described as the main cause of premature mortality and the sudden death in patients with RA. This is the result of process of accelerated atherosclerosis, where the chronic inflammation appears to play an important role in development of subclinical atherosclerosis and the cardiovascular events in patients with RA. The serum level of some metabolic syndrome-related biomarkers, adipokines, and the biomarkers of endothelial cells activation and inflammation have recently been found useful for the prediction of cardiovascular disease in these patients. Hyperhomocysteinemia, which is a strong risk factor for arterial thromboembolism in coronary, cerebral, and peripheral vessels and venous thromboembolism. The elevated levels causes detachment of endothelial cells from endothelium and increase the albumin permeability in the endothelial cell layers. It also inhibits the DNA synthesis by causing breakdown in the DNA chain with endothelial cells, resulting in attenuated repair capability of the cells. The leptin, which is a component of the cytokines network, which mediates immune response, play an important role in the T-cell related inflammatory process and modulate T helper cell activation in cellular immune response. It activates monocyte macrophage cells and increases the production of pro-inflammatory cells like TNF alpha and interleukin 6, and also has the ability to convert the T cell into T helper phenotype, T helper 1 phenotype, and release of interleukin 2 and interferon gamma, resulting in acceleration of process of inflammation. Neopterin, which is produced by monocyte macrophage primary, is a response to interferon gamma stimulation, induced the activation of the cellular immune system. It release starts 3 days before T lymphocyte proliferation and is a peak nearly 1 week before specific antibodies become positive. It also may be used as an indicator for early inflammation. In this study, we aim to determine the serum homocysteine, leptin, and the neopterin level in patients with RA and investigate the relationship between the clinical and laboratory parameters of disease activity in the presence or absence of extra-articular manifestations. We involved 80 consecutive patients with established RA and also involved 80 age and 6 matched healthy control. The mean disease duration was 9.5 plus or minus 7.3. The inclusion criteria were fulfilling ACR ULAR rheumatoid arthritis classification criteria, and we excluded all patients with hypertension, hyperlipidemia, cardiovascular disease, previous cerebrovascular disease, and thromboembolic events. We classified our patient into our population into three groups: 40 with non-extra-articular manifestation, group A, and 40 with extra-articular manifestation, group B, and the 80 healthy persons as control in group C. Those patients with extra-articular manifestation have the following character. Eight patients of them have cutaneous vasculitis, some patients have nodules, and some has neuropathy, Raynaud's, secondary Sjogren-Felter syndrome, interstitial nephritis, interstitial lung disease, with main patients having cutaneous vasculitis and secondary Sjogren syndrome. Regarding our results, there was a significant difference between RA patient and control regarding hemoglobin, ESR, TNF-alpha, and interleukin-6, while no statistically significant difference was found between RA and control group regarding serum leptin, while significant difference was found regarding Neopterin and Homocysteine. Also, there was significant difference regarding serum Neopterin and DAS28-ESR between RA patient with extra-articular manifestation and those with non-extra-articular manifestation, and there was positive significant correlation between Neopterin and the Homocysteine with ESR, TNF-alpha, interleukin-6, and DAS28, while no significant correlation with the CRP. Also, our study showed that DAS28 and ESR were the main predictor for high Neopterin levels in our patients. The conclusion of our studies: leptin level didn't seem to reflect disease activity in our study, and we recommend further research on leptin hormone in relation to the hormonal changes in rheumatoid arthritis patients, and more studies on the influence of leptin on immunity in relation to the metabolic state, aiming to reach new approaches that may focus on nutrition for modulation of the immune response. And also, we concluded that serum Neopterin can be used as a sensitive marker for assessing background inflammation and disease activity score in RA patients, while serum homocysteine can be used as a marker for probability of extra-articular complication of RA. And given the serious impact of the increased risk of atherosclerosis in rheumatoid arthritis patients, future work should focus both on understanding the precise molecular mechanism that led to premature vascular damage in inflammatory arthritis, and on assessing the individual effects of various treatment on cardiovascular disease in these patients by performance of rigorous studies. And the further studies should also focus on the development of effective screening methods for identification of those patients with who are at the highest cardiovascular risk and who would benefit from early intervention. Thank you for all.
Thank you very much for the organizing committee for letting me to chair the session for the second GCC Rheumatology Conference. The second abstract will be presented by Zainab Kallow. She's a rheumatology registrar working in Royal Hospital, Muscat, graduated from Kufa University, Iraq in 2019. The topic of her research is Tofacitinib in patients with rheumatoid arthritis, real-world data. So the microphone is yours, Dr. Zainab.
Hello, my name is Dr. Zainab, one of the junior doctors in rheumatology team, Royal Hospital. I will be talking about a study conducted by our department investigating the safety and efficacy of Tofacitinib in rheumatoid arthritis patients. As we know, rheumatoid arthritis is one of the common autoimmune inflammatory diseases that involve the joints as well as other systemic organs. It accounts around 1 to 3% of population worldwide. There are many traditional efficacious management options for rheumatoid arthritis, including the conventional DMARD, biologic DMARD. Tofacitinib, regarded relatively a new medication that approved for rheumatoid arthritis, and it's a new class of drugs that called targeted synthetic DMARDs. Usually it works by inhibiting the immune response and preventing the inflammation and the structural damage of the joints. It can be given as a monotherapy or in combination with methotrexate or other non-biological DMARDs. So looking back to literatures, there was a study conducted in Canada between 2014 and 2017 for patients with rheumatoid arthritis who used tofacitinib as a medication, as a management for them. What they found that there was a good response and increasing number of patients who used tofa in patients who were biologic naive compared to patients who failed biologic before. In the same concept, also Australia and China conducted a study for tofa, and they concluded that patients reach a clinical remission and remission in DAS28 ESR during the period of tofacitinib management. So as mentioned earlier, the aim of our study is to investigate the safety and efficacy of tofa in rheumatoid arthritis patients. We did an observational study conducted from 2017 till 2020. All patients' data, disease activity, routine labs were collected from the electronic medical records in the hospital. And also we have screened the patient for latent TB, hepatitis B, hepatitis C at time of diagnosis and before initiation of tofacitinib. All our patients who included in the study were diagnosed with rheumatoid arthritis based on EULAR ACR criteria as shown here. In view of the results, 79 of patients were enrolled in our study, mean age 53 years old, majority of them were females of 91%. This table can show the baseline disease characteristic before initiation of tofacitinib. And as you can see, the disease duration, mean disease duration around 86 months, with the mean baseline DAS28 around 5, which showed high disease activity. In regards to serology test for the patients, majority of them were high positive anti-CCP and rheumatoid factor versus only 5.1% and 12% respectively negative anti-CCP and rheumatoid factor. Here, as we can see, this chart show patients who were on a previous DMARD before initiation of tofacitinib. And it's obviously that all the patients were on a previous DMARD before starting tofa. Majority of them were on methotrexate, around 83% of the patients. Regarding this chart, show patients who were biologic naive versus patients who were on a previous biologic. And majority of the patients, around 59%, were on a previous biologic versus only 34% of patients were biologic naive. And the pie chart can tell how many biologic used before initiation of tofa. So during tofa's treatment, majority of them were on concomitant with methotrexate in a percent of 89, versus only 3% of patients were treated as tofa monotherapy. In regards to the efficacy of tofa, as we can see in this table that showed the disease activity markers, including the total tender joint, total swallow joint, inflammatory markers, and DAS28, We have measured these variables initially as a baseline at 0 time, and then every 3 months period. So we have noticed that there was a statistical improvement in the total swallow joint with a positive p-value over the 3 months and 6 months. The same notice was in total tender joint with positive p-value and the DAS28 over 3 months, 6 months, and 12 months. On the other hand, 20% of patients had suboptimal adherence, while 44% of the patients had treatment interruption. Most of our patients, the reason of interruption was delay medication supply from the pharmacy. If you can notice here that around 50% of the patients, half of the patients, had withdrawn the medication. So this pie chart showing the reason of withdrawal of Tofacitinib among our patients. Majority of them were due to lack of efficacy. They weren't satisfied about the results, while around 13% of patients due to adverse events. As you can see, the common adverse event that recorded in our study, one patient, she developed ovarian cancer during around 3 to 6 months time of initiation of Tofa. Other patient developed oral thrush and then decided to stop the medication. The rest due to persistent headache. So it's important to mention that patients who were on a previous biologic had a higher percentage of failure, around 73%, compared with patients who were biologic naive. And it was recorded based on EULAR response criteria. And this supports the Canadian study that was mentioned earlier, that despite Tofacitinib is a good option for management of intractable rheumatoid arthritis, but still it has lower effect on patients who failed biologic. One important thing also we have noticed in our study that majority of patients were on concomitant methotrexate along with Tofacitinib, and those group of patients had shown an improvement compared with Tofa as a monotherapy. So now let's move to the safety. Actually, we haven't noticed any major clinical or biochemical alarming signs or symptoms or laboratory changes during our study. Generally, it has a consistent safety profile with no recorded serious infection or activation of latent. This table showing the routine investigations that were conducted to the patients during each follow-up visit. And we haven't noticed any significant derangement in the investigations or decline in renal function, liver function, or derangement in LFT. So in conclusion, our study is a promising study that showed a significant statistical improvement in disease activity markers. Concomitant treatment with methotrexate have shown a good response compared with Tofa and as a monotherapy. Patients who failed biologic before will have less response compared with biologic naive. Some limitation in the study that we have to mention, including the small number of patients that definitely will affect the accuracy of long-term safety and efficacy of the study and of the medication, as well as the treatment interruption due to delay in pharmacy supply. That's the end of my presentation. Thank you.
Our next abstract will be presented by Ahmed Sabr. He's Assistant Director of Research and Grant Office at American University of Kuwait. Worked as a consultant for statistical studies. He targeted material and environmental rheumatology studies and time series of diabetics. He is a reviewer for more than 20 international journals. He's going to talk on long-run relationship assessment of air pollutants on rheumatoid arthritis disease activity score, evidence from the VECM approach. The microphone is yours, Dr. Ahmed.
My name is Ahmed Sabr. I am a PhD researcher in the University of Strathclyde from Glasgow, United Kingdom. Today I will present my research that about long-run relationship assessment of air pollutant or rheumatoid arthritis RA disease activity score using DAS28 index. This evidence was proved using a new approach of multivariate time series approach, which is called the vector error corrected model. The idea of this research, as we are aware from the World Health Organization, there is a relationship between air pollutant toward the health aspects, and that caused the death for more than 7 million, and that was reported in 2021. And as you can see from those percentages, the 43% of all dead people are from chronic disease, that including the rheumatoid arthritis. World Health Organization, they specified 5 pollutants. They have the direct effect on the health of the human being, and those pollutants are sulfur dioxide, SO2, O3, carbon monoxide, particulate matter, which is BM10 and BM2.5, in addition to nitrogen dioxide, which is NO2. Some scholars, they discovered this relationship, and they found that more than 7 or 8 million, they died because of the pollutants, and we have some several research, as you can see from this slide. Back to literature, some literature, they discovered the relationship between the pollutant and the arthritis, rheumatoid arthritis. One of the most important literature here, we have a study related to heart. 2013, she discovered that there is a relation between the pollutant, NO2, SO2, PM10, toward the rheumatoid arthritis. In addition, there is another study from China. They found that BM2.5 and NO2, it's a risk factor to increase the rheumatoid arthritis. Also, we found a Korean study. They found that CO3, the ozone, controlling the rheumatology arthritis among the patient. In addition to that, we conduct a study in Kuwait using a data from CARD, and we found that there is a relationship between NO2 and SO2, and this paper was published and it's nominated for awarded prize. In addition to that, we create some meta-analysis, and we found that most pollutants among the researchers, there were nitrogen dioxide, NO2, and BM2.5. Those are the most two important pollutant that controlling the disease activity score for the RA patient. Our aim and objective for this research, we need to discover and to examine the relationship of these pollutants, NO2, SO2, and ozone, toward the RA disease activity score using a disease using DAS28 from the time dimension, and that's why we are using the vector corrected model, which is a multivariate approach, multivariate time series approach to explain the relation between the disease activity score and the pollutant across the time. In addition, we need to discover if those pollutants will have like a short or long run effect among the RA patient to control the disease activity score DAS28. The method that used for this study, we have two sets of data. The first data came from CARD, the Kuwait Registry for Rheumatic Disease, and this data set contained like 1,800 patients with more than 10,000 daily visits. We use the daily visit to link it with the daily pollutants and pollution in Kuwait. In addition to this database, we have another database related to EPA, Environment Public Authority in Kuwait, and we use the data from the EPA and we link it with the patient profile. The period of the study, it was between 2013 up to 2020. In addition to that, we have like more than 18 monitor station. We select the most 4 stations surrounded in Kuwait and with the high level of living addresses. As you can see, those are the 4 stations that we have selected to explain the relationship between the disease activity score and the pollutant. Also, we transfer and convert the daily pollutant using the exposure or the concentration to some index which is called the air quality index using this formula. We use the software to find the relationship and to build a model using the vector error corrected model. The idea, as I mentioned, we need to transfer the data from air pollutant to the patient profile. And we try to fill all the data using the patient profile visit. Those are the parameter and the variable used in to build the time series multivariate time series model. Some variable came from the rheumatic disease, and the other variable came from the pollutant and air quality index. This is the idea of the model. We use the multivariate time series because we don't deal with one dependent variable. We have set of dependent variable, and we need to see the effect from the air pollutant toward the disease activity score. I will skip this slide because it's more explanation about the approach. Here we are using some testing method because we need to see if the model predicting the accurate prediction to predict the disease activity score or not. We are using those tools to explain the error of this prediction. Those are some results from our study. This is the demographic came from the study. And also this is the disease activity score using ESR's CARB hack disease -28, and we use some advanced approach because we have some missing data, and we do some imputation approach using mice approach. And this was published in Rheumatology, Rheumatic Disease Journal. This is the regression model, and we found here we have 4 locations, and each location we have the relationship between the disease, the pollutant, or the disease activity score for each pollutant. Here are the time series graph. We can see here the gray line represent the disease activity score, the red line represent the pollutant for each station. We can see that there is like a common movement around the time between the pollutant and the disease activity score. And here the vector error corrected model result, as you can see, and especially in this location, we found there is a clear relationship between disease activity score and the pollutant across the time, and this is protecting the long run effect. This is the model table result. We can find that there is some accepted parameter and rejected parameter depend on the nature of the area. Some area located with the pollutant resources, the other area are not. The conclusion of what we have done, our results show that increase of concentration of pollutant and O2 as O2 may increase the risk factor of disease activity score +28 or CDI. Also, the Johansson test confirmed there is a long-run relationship between these 2 pollutants on the disease activity score. In addition, our model, vector error corrected model, confirmed that those pollutants predicting the disease activity score. Also, we found the relationship between air pollutant to predict RA activity can be seen for the 7 or 8 days. The other conclusion comments is related to the policymaker to take care about the increasing of the disease activity score on the the increasing of the air pollutant on the disease activity score by sending some messages to those patients and to aware them about how this will risk on their life. Thank you for listening, and I hope you are enjoying about what I have and what I discovered from my research. Thank you.
Okay, thank you all for this excellent presentation. And the chat box, I don't see any questions, so I may ask some questions, Dr. Yasser and Dr. Zainab. Okay, Dr. Yasser, what's the added value of measuring these, which is the leptin, Neopterin, and Homocysteine in rheumatoid, since we can measure the activity with ESR-CRP and cholesterol, doing cholesterol level and lipid. So what's the value of these?
Yes, we choose some biomarkers that may play important role in the pathogenesis of the inflammation, especially on the cardiovascular problem on patients with RA. And we try to make correlation with these inflammatory markers that you mentioned now, like ESR, CRP, and all of these, trying to make a correlation between the normal, what we found on our practice, and the pathogenesis itself. Also, we try to choose what is the best markers from these ones that we use, like ESR, CRP, DAS28, or cholesterol level or lipid profiles, to judge or to choose the patient who has a risk of developing cardiovascular risk in the future. And we found a good result for that, like with homocysteine and with Neopterin, while leptin in our study, but in other studies, leptin has good correlation with these biomarkers.
Okay. Dr. Zainab, I saw your the mean age of your rheumatoid is 72 years. This is very high age, right, for rheumatoid arthritis. Can you explain to me why? Because we did here in Kuwait, we have between 40 to 50, but yours is 70 years. Yeah.
Actually, the mean was in the 50.
But you showed us 70.
No. It was in
150.
Yeah. But it's ranging from the 20 to 70, but the mean was 53, around 53, with majority were female.
I see. Yeah. Okay, so Dr. Sabr, I don't know the pollution, we're not doing in Kuwait, but is there any relation between rheumatoid and cold weathers or not? Because you see that flares increase in winter or they get more pain. Can you have any this pollution, the SO2 or nitrogen or oxygen in winter period?
Yes, when I conduct this type of relationship between the air pollutant and the RA factors, the air pollution can be divided into two places. The climatology, which is the temperature, the humidity, wind speed, wind direction, and the other factors related to the pollutant. From the climatology factor, we found that the humidity, the relative humidity controlling the disease activity score. What we found is the more, like when the humidity goes up, when we increase in, if the humidity goes up, the disease activity will goes down. This is what we found from our result. Yeah, but regarding the temperature, I didn't see any relationship between the temperature and the disease activity score, but in the other scholars, they found there is a relationship, maybe because we are living in, the whole year we are living in the summer, so there is no big difference between, increasing number of temperature or decreasing.
Okay. This question to Mr. Ahmed Al-Sabr. We know pulmonary disease have high mortality in rheumatoid. Did you look at association of lung disease of rheumatoid arthritis patient and pollution and pollutant? Like there is a specific pollutant out of these led to pulmonary fibrosis in RA patient?
Okay.
Did you look for, yeah.
You mean the other pollutant?
Yeah. The affection of the lung in rheumatoid arthritis. Are there any pollutant? You looked in the lung, or you didn't look in these patients?
No, I didn't search for the other type of disease, but in my research, I focus on 3 types of diseases, which is diabetics, RA, and COVID patient. So I measured the relationship between the air pollutant, the pollutant that I mentioned, which is the 5 pollutant, how those pollutants are controlling the increasing number of the diabetics patient and RA with the COVID-19 patient. I found some pollutant controlling the number of cases in Kuwait.
But not on lung affection, right? In rheumatoid arthritis.
No.
We don't know yet. No.
I didn't go to that area.
No. There's another question to you. From which area the pollutants were measured? Which area in Kuwait?
Yes, in Kuwait, we have like 18 monitor fixed station surrounded in Kuwait, but those monitor fixed stations are very close to each other. So we selected 4 monitor fixed station that is surrounded with the most residential area. So I think I was mentioned that in the map of Kuwait, there is one in the north, which is in Jahra, and one in the middle, which is in Mansouriya, and 2 from the south, which is Ali Subah al-Salim and Fahihi. Those 2 in the south, one related to industrial area and the other one related to residential area. So what I found from my result, the patient who living in the north, they have some problem with this type of relationship, because the nature of Kuwait, most of the wind direction came from the north and the west, and they shifted the pollutant from north to those people who are living in the north side, and those pollutant will be shifted to the seaside. But the people who living in the south area, they are less, less affected by the pollutant.
Okay.
Yeah.
There is a question to Dr. Zainab. Is there any case of herpes infection in your study?
Yeah, actually, there was no activation or no infection in herpes zoster in our study. No, we didn't find even any infection, significant infection. Yeah.
Dr. Musallam, any questions from your side?
Just for the Dr. Al-Sabr, is there any increase the incidence of RA on those highly polluted area comparing to the other regions? Have you looked at that from the registry at least?
Yes. What we found is because we link the information according to the living area, and we found the people who are living in the north side, they have a high level of DAS28. If we compare it with the people living in the south area, So this is one of our findings, because in the north area we have some power plants and major power plants, and I think that is the main resource of this pollutant area.
Okay, I think we have to stop now because we're running out of time. Thank you all, and good luck for all of you. Thank you very much.
Thank you.
Thank you.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory HEAL enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of HEAL enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
Good morning, doctors. It's my pleasure to be with you today. This is Ahmed Gamal from Pfizer, the country brand manager for the I&I portfolio. It's my pleasure to be with you today. And firstly, I want to thank all the committee for the GCC conference and for the organizing committee also for this conference and giving us this opportunity. Today is my pleasure also to introduce one of the eminent speakers in our region, who is Dr. Adiba Al-Herz. Dr. Adiba is currently a consultant in internal medicine and rheumatology in Al-Amiri Hospital, Kuwait. Dr. Adiba is the founder of Kuwait Registry of Rheumatic Diseases and the team leader. Former Dr. Adiba was the president of Kuwait Association of Rheumatology, which is CAR. Former head of Osteoporosis Committee. Former member of the Higher Medical Council of Persons and Disability, and also she is a tutor in faculty of in the Faculty of Medicine for undergraduate medical students and tutor in Kuwait Institute for Medical Specialties. Today, actually, Dr. Adiba will talk about a mark of experience review for clinical trials for Tofacitinib, and also she will take us through the local registry for rheumatology in Kuwait. So it will be like a blend between international and also local data. So Dr. Adiba, the floor is yours now.
It's my pleasure to be with you today, and I'd like to congratulate the GCC, the second GCC committee and the organizers for such a successful meeting. And I hope the next today and tomorrow will be even better than before. So it's my pleasure to be part of this symposium on JAK inhibitors, the Xeljanz. Actually, JAK inhibitors, in particular Xeljanz, because Xeljanz is the first one to be in the market, at least in Kuwait and in the Gulf area. And the highest number of, it has the highest number of studies and the data from real world. So it's made a great evolution actually in the history of not only rheumatoid arthritis, but in the history of rheumatic diseases, just like when the steroid had made an evolution, and then methotrexate, and then biologic treatment. And I think we are in the era of JAK inhibitors now. So let's shed more light, especially that for the last period of time, there was an issue raised about the safety of Tofacitinib and JAK inhibitors in general. So let's shed more light on these issues. So these are my disclaimers. And as you can see here, and as I said, Tofacitinib and Xeljanz has been the first JAK inhibitor in the market. So it has the highest number of studies and different kind of population here. Here we have the patients who are using JAK inhibitors, or sorry, Tofacitinib as monotherapy here. And in methotrexate naive, I'd like to bring your attention that Tofacitinib hasn't been approved to be used in methotrexate naive patients, but still in real world and in practice, like in Kuwait, for example, we've been using Tofacitinib in methotrexate naive patients in so many patients, and we have data on these patients. Also, it's been used in patients in combination with methotrexate and then other DMARDs, for example, here in the SYNC study, and then in the standard, and that's in comparison with adalimumab, and then in the SCAN, and that's focusing on the radiographic progression, and in the STEP, and that's after failure of anti-TNF, and the strategy, which is a very interesting study because it compares between Tofacitinib and adalimumab. I'd like to bring your attention here that the design of the study was not a superiority study. It's a non-inferiority study comparing Xeljanz with adalimumab. So these are the different kind of populations. So we'll see the efficacy and the safety in those populations in addition to real-world data. So in all these studies that I've mentioned, Tofacitinib has been proved to be very effective. So that's in solo, as monotherapy. So very good numbers as compared to placebo using Tofacitinib as monotherapy. And here the start as well in methotrexate naive and in combination and in comparison with adalimumab, you can see that the numbers are slightly higher than the numbers in adalimumab. But again, I'm telling you, this is not a superiority study, it's a non-inferiority. So statistically, we can conclude from this study that it's not inferior to anti-TNF with regard to efficacy. And even the step here, the patients who are intolerant to anti-TNF. So we have very good numbers as compared to previous anti-TNF. So, as I said, maybe the most important reason why we're here now is to shed light on the safety of Tofacitinib in particular and JAK inhibitors in general. So we learned from the RCTs that there might be an issue. So let's see how real-world data confirm or either agree or disagree with that conclusion. So when we talk about RCTs, the RCTs use selective number of patients. So they have many inclusion criteria, many exclusion criteria. We want patients like with moderate disease activity, not mild, not severe. We don't want patients with comorbidities. We don't push patients with complex comorbidities or hepatitis or TB or pregnancy, like so many conditions to enroll the patients in the RCT. And that does not reflect real practice, because in your clinic, we have a mixture of populations. And in the study, there was one study, I think it was the DREAM study, that showed that about half of the patients that are seen in the real world data or in the clinics, they do not fit the inclusion criteria that are used in the RCTs. So our patients, they do not reflect the patients that are seen in the RCT. So we cannot just import the data in the RCTs and use them for our patients. We have to use data from the registries that we have worldwide. So as I said, Xeljanz was the first one. So it has a very high number of studies in different kind of populations. However, the other JAK inhibitors, they also have studies in other kinds or in different kinds of populations like Bari, the Opada, and the Filgotinib. For example, the Baricitinib, they used also patients from real-world data, and they focused on the safety, and they showed that Baricitinib was quite safe in different kinds of populations in terms of infections, malignancy, etc. So let's focus on Tofacitinib. So for Tofacitinib, the real-world data that we used was coming from the Corona, and which was previously changed the name because of the coronavirus. However, I'm still using the old terminology or the old name for this registry. And we have the other databases, mainly from the insurance, from the US insurance. So these are the biggest insurance database that I'm going to focus on to use the data for the safety. So let's start with the serious infections and herpes zoster. So these are all the adverse events with all the percentage, and that's per 100 patients years. And these are the numbers for herpes zoster and serious infections. So let's talk more about it. Now, I like this study. It's called the oral surveillance. So in the oral surveillance, there is a focus on malignancy and MACE, which are the major adverse cardiovascular events. So what's interesting in this oral surveillance that I like is that they focus on patients with cardiovascular risk factors. So they took the more elderly patients. I wouldn't say elderly, but middle-aged to elderly. So that's 50 years and above, with one or more cardiovascular risk factors, including hypertension, diabetes, myocardial infarction, smoking, like all the cardiovascular risk factors. So they took this population with cardiovascular risk factors, and they tested this population whether they have more serious events or more cardiovascular events when they use Tofacitinib. And I'd like to tell you here that well, they divided the patient into Tofacitinib 5 milligrams and 10 milligrams, of course, BID, and biologics like Adalimumab and Etanercept. And here I want to tell you that patients on Tofacitinib 10 milligrams BID, at one point, they had to switch them to Tofacitinib 5 milligrams BID. The reason for that was that the 10 milligrams BID, they had a higher rate of mortality and a higher rate of venous thromboembolic conditions, so they had to lower down the dose. And I'd like to bring your attention and remind you that Tofacitinib in the dose of 10 milligrams BID is not approved and not indicated for the use in rheumatoid arthritis. So we're not in real life, and in our practice, we do not use 10 milligrams BID. The usual dose that we use is 5 milligrams BID. Now, this is the oral surveillance that I was talking about. This is focusing on serious infections. And what they did here, they divided the patients into less than 65 years and more than 65, and they found that Tofacitinib was similar to patients on anti-TNF in terms of serious infection, and that's applied for less than 65. Let me just get my pointer. 1 second. Okay. So that's applied for both populations, the less than 65 years of age and more than 65 of age. So the rate of serious infection is similar whether the patient is old or the patient is younger. However, when you use Tofacitinib in the dose of 10 milligrams BID, then the rate goes higher. And as I said again, it's not indicated to be used for rheumatoid arthritis in that dose. Now, this is the US Corona Rheumatoid Arthritis Registry, and that's a big registry in the United States, and that's over at least 5 years, and it has a big population, and most of the population, they have a high disease activity, and the mean age was in the, let's say, around 60. So very good group of patients with rheumatoid arthritis to test. So this is the rate of serious infection, and this is the serious infection on the left side, and this is the PS trimmed and matched. The PS is, they match the population according to the confounding factors. In the trimmed, they use the logistic regression, and in the match, they use the usual matching statistical method. So they do that because they want to make the data more accurate and more powerful. So they exclude all the confounding factors. So it's a more accurate result than we see normally. So these are the serious infections, and you can see that the similarity between the biologic DMARDs and Tofacitinib, whether it's matched or trimmed. Now, if you look at herpes zoster, again, herpes zoster, we already knew that Tofacitinib and all the JAK inhibitors have a higher rate of herpes zoster as compared to biologic DMARDs. This is the US multi-database that I talked about, the ones with they use for insurance purposes, and this is the rate of hospitalization. So the number of patients is really great, and the population is like middle-aged to elderly patients. And in these databases studies, we can see here, I just want to explain to you what's going on here. So these are the different biologics. So if you look at the left side, this is in favor of Tofacitinib. If you look at this side, this is in favor of the other biologics. So what we can conclude in general here, that the rate of hospitalization is similar between Tofacitinib and biologic DMARDs in general. However, the Tofacitinib was better than infliximab here, and the data was in favor of Enbrel or etanercept here. However, if you look at the other biologic DMARDs, so they are very similar statistically to Tofacitinib. Now, if we divide the patients to younger age group, less than 65, or older age group, more than 65, again, we can see that most of the biologics will have similar numbers in terms of hospitalization. If you look at the younger age group, it will be in favor of Tofacitinib if you want to compare it with infliximab or tezolizumab. If you look at the elderly population, the data will be in favor of tezolizumab and etanercept, that's in the elderly population. However, for the rest of the biologics, the rate of hospitalization would be similar between the biologics and the Tofacitinib. So that's about the serious infections. Let's look at MACE, which is the major adverse cardiovascular events. And you can see that the rate is 0.4 per 100 patients years, and that's the long term, around 10 years. And that's the MACE in the corona registry. So on the corona registry, again, we're using the propensity score. And as I said, the propensity score is very accurate because you're excluding all the confounding factors. And you can see that the rate, whether it's matched or trim, the rate is similar in the MACE between the Tofacitinib and the biologic DMARD. So statistically, there is no difference between them. And this is the oral surveillance that I talked about, focusing on patients with cardiovascular events and patients older than 50 years of age. So again, looking at the graphs here, very beautiful graphs here showing that there is no difference in terms of MACE or major adverse cardiovascular events between the Tofacitinib and patients who are on anti-TNF. Let's look at VTE, or venous thromboembolism, and that was the issue which was raised by the RCTs. And you can see the rates here between 0.1 and 0.2 per 100 patients years. So again, you can see from real world data that you can see statistically there is no difference between patients on other therapies and patients on Tofacitinib in terms of DVT and PE. However, if you look at Tofacitinib in the dose of 10 milligrams BID, you can realize the difference here. So it's lower with anti-TNF. So it's higher. In other words, if you use the Tofacitinib in a dose of 10 milligrams BID, you can get a higher rate of PE in those populations. However, again, I want to remind you that this dose is not approved to be used in rheumatoid arthritis. And not only rheumatoid arthritis, but also SPA, so like in rheumatic diseases in general. However, if you look at the 5 milligrams BID, although the numbers tend to be higher than anti-TNF, but statistically, there is no difference between the anti-TNF and Tofacitinib in terms of DVT or PE. So you can see that it's crossing the midline, so statistically the numbers are the same. And that's again for the VTE, and that's from the corona registry. Again, from the corona registry, the numbers are the same, the rates are the same between the Tofacitinib and the biologic DMARDs. And this is the risk, this is using the US database, Again, I just want to remind you that a huge number of patients, like 48,000 patients, were using the Tofacitinib, and that's conducting the data on the results. I mean, from these databases, again, it's crossing the data line, and there is no difference in VTE between the Tofacitinib and other rheumatoid populations. So let's look at malignancy, whether it's not non-melanoma or the other kinds of malignancy, and these are the rates that we have per 100 patients year. And you can see here that this is the malignancy and this is the non-melanoma. And again, using or excluding the confounding factors, you can see that the rate is similar between the Tofacitinib and the biologic DMARDs, using either the trimmed or the match, and that's for all the malignancies or the non-melanoma skin cancer. So the rates are quite similar between them. And this is the oral surveillance, the safety surveillance that we talked about. Again, it's crossing the midline, and there is no change between, no difference between the Tofacitinib and the other DMARDs. How about mortality? Now for mortality, which is 0.3, which is very similar to the other drugs. And you can see that for the mortality, and that's by dose, so that's all Tofa, and that's the 5, and that's the 10. So for here, that the rate is similar. So that's in the RCT. The rate is similar in the RCT between all doses of Tofacitinib. However, in the oral surveillance, if you look at the higher dose, again, the high dose of Tofacitinib, statistically, there is a high rate of mortality, and that's why in the oral surveillance, at one point, they had to switch the 10 milligrams to 5 milligrams. However, if you look at the 10 milligrams, statistically, there is no difference between the Tofa and the other group. Now, in the corona, again, using the trimmed and the match, the mortality rate is similar between the Tofacitinib and the biologic DMARDs. So in summary, for the safety here, although the RCTs showed, and of course, an increased risk of herpes zoster, so that's already we know for all the JAK inhibitors. There was an alarming signals about the VTE in the RCT, and that's why the EMA prescribing information, they showed an alarm regarding the VTE with the use of JAK inhibitors. However, we say that the RCT does not reflect real-world practice, but in the real-world practice, and according to many registries, especially the American registries showed, with a huge number of patients, they showed that the adverse events had similar rates between the Tofacitinib and the other and the biologic DMARDs, of course, except for the herpes zoster. There was no significant increase in the VTE or serious infections, irrespective of age group. And in the US database, numerically, there was a trend toward a higher number, but statistically not significant increase in the VTE in RA patients. How about so we showed so far, I just want to summarize what we said, that the real-world data did not confirm the alarming signal that came from EMA regarding the rate of VTE or whatever, DVT or any other adverse events that may come with Tofacitinib, and the real-world data, of course, that reflects our real-world practice in our clinics. However, there was an increase in the 10 milligrams BID of Tofacitinib, which is not the indicated dose. And all other adverse events were similar between tofacitinib and the biologics. Now, regarding the persistence of JAK inhibitors, now, when I prescribe a medicine in my clinic, I don't want a patient, even though if he's doing well from the beginning of the therapy course, I don't want him to show up in my clinic after 1 or 2 years and the disease is flaring up. I need a drug that gives me a peace of mind that even after many years, after 5 or 10 years, the patient will remain in remission because I'm dealing with chronic diseases, and I need a drug that gives me a peace of mind and that gives the patient a peace of mind. And that's what we are studying here, the persistence of effectiveness of JAK inhibitor or tofacitinib in particular. So the RCT confirmed that tofacitinib is not inferior because that's the design of the study, the non-inferiority compared with adalimumab. And in real-world data, they confirmed the persistence of efficacy of tofacitinib as compared to biologic DMARDs, in particular adalimumab, and it showed that if you want to compare tofacitinib with biologic DMARDs, it has similar efficacy and persistence over the biologic DMARD. So let's shed more light over this issue. So this is the OPAL-COMI, which is the Australian registry, and again, they have high numbers of patients with severe RA, with seropositive, and with a good age group, like a mean age group of 60. And they showed, I like this slide, it's very interesting because many of our patients, they don't like methotrexate and they stop methotrexate after some time. So tofacitinib here showed that you can use it as monotherapy. And this is the rate of using JAK or tofacitinib as monotherapy. So it's 43% as compared to 33% in biologic DMARDs, which is statistically different. So tofacitinib has a higher rate of being used as monotherapy as compared to biologic DMARD. Now, what's more interesting in this slide is that as time goes on, the rate of using tofacitinib as monotherapy is higher than biologic therapy. So here, after 19 to 26 months, so the rate goes from 43% to 49%. And still, it's statistically different than biologic DMARDs. So just to translate it to real practice, for example, if I have a patient on tofacitinib and I just started tofacitinib for him, and this patient, or let's say this group of patient, a certain percentage is using monotherapy, a certain percentage of tofacitinib patients are using monotherapy. After 1 or 2 years, the rate of using tofacitinib as monotherapy increases in those patients. So there is a tendency to use tofacitinib in the future more as monotherapy. And that's what we do in real practice, because sometimes when we give tofacitinib, we can either stop methotrexate and start tofacitinib, or we can combine them, and then after some time we take out methotrexate and then we continue tofacitinib as monotherapy. And this is in the persistence compared with biologic DMARDs in terms of DAS28 or in terms of CDAI. Again, there is a persistence in the efficacy, and there is a similarity to biologic DMARDs even after years of using tofacitinib. And this is the Swiss registry that we talked about. So let's see what's happening in the Swiss registry. So you can see the drug maintenance here, and this is the drug maintenance actually was significant. The overall drug maintenance was significantly lower as compared to the maintenance was lower with TNF. So Tofacitinib, this is the blue line. So you can see the blue line here, and it's better after 3 years over the anti-TNF. So for example, if you have patients on Tofacitinib and patients with anti-TNF, the likelihood of having persistent with Tofacitinib is higher than the anti-TNF, and that's what we read from this slide. And this is the drug discontinuation. This is the discontinuation because of insufficient effectiveness, and this is the discontinuation because of adverse events. So the likelihood here, there is an increased risk in the anti-TNF here because of the TNF is likely to be discontinued because of lack of efficacy, but the Tofacitinib, the reason is because of adverse events rather than lack of effectiveness. So this is Baricitinib as well, because we're also talking about all the JAK inhibitors. So again, there is a persistence of Baricitinib over the anti-TNF. So JAK inhibitors is not only Tofacitinib as a drug, but also it represents the group in the persistence of efficacy. And this is the JAK SPOT collaboration. So it collaborates 17 rheumatoid arthritis registry, European registries in different regions. And again, there is a retention of JAK inhibitors over the anti-TNF even after 3 years of using the drugs. And this is the Kuwaiti data. So I want to shed more light on the Kuwaiti data. So you know that we have a big registry on rheumatoid arthritis in Kuwait, and this is focusing on Tofacitinib. So what we did here, we divided patients on Tofacitinib into combination patients with DMARDs and on monotherapy. And we have shown that the p-value is not significant for all these factors if you're using Tofacitinib as monotherapy or as combination. So Tofacitinib is as effective as monotherapy as in combination therapy, whether we're talking about DAS28, CDAI, SDAI, swollen joints, even HAC is not significant between the two groups. And this is after 10 years. So this is patients using Tofacitinib. After 10 years, all patients on Tofacitinib, whether a combination or monotherapy. And you can see the drop in Tofacitinib over the drop in DAS28 over time. This is the drop in CDAI score over time. This is the VAS pain score. This is the HAC, the drop in HAC over time. This is the ESR drop, this number of swollen joints, the number of tender joints, the patient's global assessment, physician's global assessment, the morning stiffness time, and there is a persistence of WBCs over time, so reflecting the lack of leukopenia with using Tofacitinib. And these are the adverse events, so there was no alarming signals in using Tofacitinib over the biologic therapy or any other therapy. So in conclusion, regarding the persistence, so the RCTs showed that Tofacitinib is as effective as TNF, not only initially, but even there is a persistent of efficacy over time, and the real-world data confirm that fact, that there is a persistence of efficacy of Tofacitinib over many years of using the drug. So there was a similar rates between biologic and Tofacitinib, and there was a lower treatment discontinuation with Tofacitinib compared with TNF. There was similar persistence with monotherapy on combination therapy for Tofacitinib and other mode of actions, but lower for TNF mono compared with TNF combination therapy. And thank you very much for being with us. And the floor is open for discussion if you have any question.
Thank you so much, Dr. Adiba. Thank you so much, Dr. Adiba, for the informative presentation where you took us through the efficacy data for the Tofacitinib, as well as you shed the light on the safety data, and especially the 1133 or the ORA surveillance, and also shared with us the international and local registers. And as expected, and as you know, that now the hot topic is regarding the FDA update, which is considered all the JAK class, and there was like a safety warning from the FDA. So we have some questions related to this topic specifically. So the first question is, in view of the recent warning issued by ACR on 28th of Jan 2022, what are your recommendations for the use of Tofacitinib or other JAK with patients known to have ischemic heart disease? And do you recommend stopping it if patient develop MI and switch to another biological DMARD?
That's a very good question. So actually, as I showed here, although there was a warning according to RCTs and according to the authorities, and we've all received that warning, but as I showed you in real world data, the real world data, which is the real practice that we do every day in our clinic, it hasn't confirmed that warning. And that's using a huge number of patients. So to translate it to my practice, actually, because I'm not convinced of these results that, or this alarming signal that was sent to us, so actually I can still use it in patients, even patients with risk factors for cardiovascular events, because there is no strong evidence for that. So you can still use it for patients with thromboembolic events or cardiovascular events until we have more stronger evidence. Now, the only thing that I advise you to do is if the patient is not responding to 5 milligrams BID, is not to go for a higher dose, because this is not the recommended dose. And this has been shown to be an unsafe dose if you use it for patients with rheumatoid arthritis, especially if they have risk factors or if these are elderly patients. In my practice, I do have patients with cardiovascular risk factors, and who doesn't have patients with rheumatoid without risk factors, because those patients are usually middle age or elderly, and most of them have risk factors. And I don't really have problems with that. And I also showed you the data from the Kuwaiti registry. We don't have this issue in the Kuwaiti registries. Now, the question is whether if the patient is on Tofacitinib and he developed a cardiovascular event, whether to stop the medication or not. That's a very important question, and I'm not sure if I'm able to answer it or not. And I think this will have a variation in individual practice, and maybe each rheumatologist will behave differently. This might be an alarming signal for me in that particular patient, and maybe in real life, not only Tofacitinib, but maybe any drug that the patient is using. If I have the choice to change the treatment, maybe I will do that. But if the patient is doing very well on that treatment and the rheumatoid arthritis could hardly be controlled on that treatment, I may tend to continue on that treatment.
Thank you so much, Doctor, for the brief answering. Also, as a follow-up on this question, so why do you think, Doctor, that the FDA has limited the approval for the JAK class for the patients who are inadequate or intolerance to one of or more TNF inhibitors only? This is as per the last statement from the FDA and ACR as well. So I think you already handled this point, or do you have another comment on it?
Just to make sure that I understand your question correctly, you mean the FDA warning or the FDA indication, or FDA warning, you mean?
Yeah, the warning, and also now like putting the JAK classes as a second line after the TNFs for the patients who are intolerant or inadequate response to the TNF. So this is now like what's mentioned, like this is the positioning now from the
That's
FDA.
Yeah, you don't mean the FDA, you mean the ACR, maybe. ACR, not the FDA. That's why I couldn't understand the question.
Yeah.
Now, the old ACR recommendations, because the JAK inhibitor was just coming to market, so they put it after anti-TNF. To my knowledge, it's been moved, and it's been moved in the EULAR as well. So now you can use the JAK inhibitor after failure of methotrexate. You cannot use it in it's not approved in methotrexate naive patient, but you can use it, and it's approved for methotrexate intolerant. Now in Kuwait, we have the liberty of using Tofacitinib even in methotrexate naive. There is no harm at all in using the patient, in using Tofacitinib as a first line drug. We have a lot of patients in Kuwait, especially young patients. When you diagnose them with rheumatoid arthritis, you can use Tofacitinib as the first line treatment. But this is not correct that you leave Tofacitinib at the end after failing anti-TNF, especially that we know this for a fact that all the drugs, if you use the drug early on in the disease course and you hit the patient aggressively from the beginning, you get a better outcome than when you use the drug late in the disease course.
Thank you so much, Dr. Adiba. One last question. What is the duration between giving JAKs inhibitors and treating cancer?
Oh, that's a very difficult question. The reason why it's difficult, because as I said previously, and I keep saying that RCTs, they do not reflect real data. So they exclude so many patients, and some of the patients that they exclude are patients with cancer. So they don't get enrolled into the studies, so that we don't know much about those patients. Because we don't know much, we cannot give recommendations for cancer patients. Now, what we normally do, and I'm sure each rheumatologist is different than the other, if the patient has an active cancer, we don't tend to give biologic therapy or JAK inhibitors. However, if the patient is cured from cancer, then maybe after 2 or 5 years. Some of the rheumatologists will give it after 2 years. Some of them will give it after 5 years. And it's not something specific for JAK inhibitor, but that's applied for all treatment kind, like for biologics and for JAK inhibitors. So in other words, what is applied for biologic therapy is applied for JAK inhibitors in terms of malignancy. In my practice, after the patient is being free of cancer for at least 2 years, I can start either the JAK or the biologic DMARDs.
Thank you so much, Dr. Adiba. Thank you so much for your time today and for the presentation. And also, I would like to thank all the doctors who attended the symposium and also the organizing committee for such opportunity. Thank you so much and have a nice day.
Thank you very much, Ahmed, and thanks for the organizer and for the Oman and the GCC conference organizers.
Thank you so much.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory heel enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of heel enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23p19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms, giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop.
Persistence is defined as the extent to which the patient continues to receive medication from treatment initiation to discontinuation. Persistence on biologic drug therapy relies on 4 criteria: efficacy, safety, favorable patient experience, and a good adherence profile. In this video, we will discuss Simpony's efficacy profile in ankylosing spondylitis. Simpony is a fully human anti-TNF with 5-year persistence rates of approximately 70% across various rheumatology indications. Improvement in signs and symptoms of ankylosing spondylitis with Simpony was assessed in GO-RAISE clinical trial. Simpony administered every month subcutaneously significantly improved ASAS measures. 55.8% of patients receiving Simpony 50 milligrams achieved ASAS 20, and 43.5% achieved ASAS 40 at week 24. ASAS 40 responders continued to increase to reach 57% at 5 years. Similarly, with Simpony 50 milligrams, disease activity scores were improved in patients with ankylosing spondylitis. 20% of patients were reported as inactive disease, and 53% of patients were reported as moderate disease activity at week 24. At 2 years endpoints, more patients reached inactive disease state, as reported in ASDAS scores, and 79% reported moderate disease activity scores. The long-term extension of GO-RAISE study has demonstrated high persistence of Simpony patients, with 72% of patients remaining on drug after 5 years. With the demonstrated long-term efficacy of Simpony in ankylosing spondylitis, it validates one of the 4 pillars to ensure a better long-term persistence. Where others stop, Simpony prevails.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory HEAL enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of HEAL enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23 P19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms, giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop.
عندما يتقدم بنا العمر تصبح عظامنا ضعيفة مع الوقت من دون أن نشعر، وتعرف هذه الحالة طبياً بمرض هشاشة العظام، وعادة لا تكتشف هذه الحالات إلا مع حدوث كسر في العظام نتيجة اصطدام أو وقوع. تتحلل عظامنا وتتجدد في توازن مستمر، وتحدث هشاشة العظام نتيجة اختلال هذا التوازن، مما يؤدي إلى ضعف العظام مع تقدمنا في العمر. بالنسبة للنساء، يحافظ هرمون الإستروجين في أجسامهن على توازن هذه العملية، ولكن بعد انقطاع التمث يقل هرمون الإستروجين، مما يؤدي إلى اختلال هذا التوازن. بعد سن 50 تعد واحدة من كل امرأتان عرضة لكسور الهشاشة، بينما في الرجال يبلغ المعدل 1 من كل 5 في نفس المرحلة العمرية. لذلك فإن الوقت هام جداً، لأن العظام المكسورة تصبح أكثر عرضة للكسر مرة أخرى، وإذا لم تعالج هذه الكسور بالشكل المناسب فإنها قد تعوق الحركة وقد تؤثر سلباً على النشاط اليومي المعتاد. ولكن الخبر السار هو أنه أصبح لدينا أدوات متعددة للمساعدة على التشخيص المبكر وعلاج ومقاومة مرض هشاشة العظام عن أي وقت سبق. اتباع نظام غذائي صحي والتمارين المنتظمة يساعدان على تحسين صحة العظام. تحسين نمط الحياة عن طريق تجنب بعض العادات السيئة وتبني أخرى صحية يساعد أيضاً على تفادي الإصابة بالكسور. هناك أيضاً العديد من الأدوية المتاحة والتي تساعد على تحسين قوة العظام وتقليل احتمالية الإصابة بالكسور. يقوم الطبيب بوضع خطة العلاج الأمثل بناء على كل حالة ونتائج اختباراتها، ولكن الأهم هو الالتزام بهذه الخطة لضمان أفضل النتائج المرجوة من العلاج. لا تدعي مرض هشاشة العظام يكسرك بسهولة، واستشيري طبيبك اليوم لتحمي مستقبلك.
Hello, everyone. My name is Julio Ramirez. I'm a consultant rheumatologist working in hospital clinic in Barcelona, Spain. I have been working in psoriatic arthritis for the last 12 years. First of all, I would like to thank to Janssen for the kind invitation to talk about guselkumab role in psoriatic arthritis. Here you can see my disclosures. Right now, we have, fortunately, so many therapies, so many options of treatment in psoriatic arthritis. Like you can see here, we have 11, 12 advanced therapies approved for psoriatic arthritis, 5 anti-TNF, 2 IL-17 inhibitors, 2 JAK inhibitors, Tofacitinib, Upadacitinib. We have ustekinumab, which is an IL-12, IL-23 inhibitor. We have also apremilast, abatacept. So the main question here is, do we need more therapies? Do we need new treatments for psoriatic arthritis? And the response is absolutely yes, because unfortunately we have a high amount of patients not reaching the goals. Like you can see here on the right, you can see that almost 40% of patients don't reach low disease activity, and almost 60% of them are not reaching remission. So that's something very, very important for us to reach remission, to reach low disease activity. So definitely we need new therapies, new options. The gold standard right now in psoriatic arthritis are anti-TNF, especially in Europe, where we have to use anti-TNF as a first option after methotrexate. They are very good treatments, they are effective, they have a very good safety profile, and the retention rate is not bad, but we know that the efficacy is losing along the time, like you can see here in these curves. So definitely we need new therapy, new options for these patients who are losing efficacy along the time with anti-TNF. Another very important issue are the presence of comorbidities. We know that almost 1/2 of patients with psoriatic arthritis, 50% of them, have any comorbidity, obesity, fatty liver disease, cardiovascular risk, and that's something very important in the evaluation, in the assessment of our patients. That's something very important to take into account when we are electing a therapy, we are choosing a therapy, and that the comorbidities are one of the main reasons why we have to stop the therapy. So definitely, yes, we need new therapies with a good safety profile. So what's in the pipeline for the coming future in psoriatic arthritis? We will have in the coming future new IL-17 inhibitors like bimekizumab. We will have new JAK inhibitors like filgotinib, and above all, we will have new IL-23 inhibitors. And among them, we can see guselkumab, which is the first P19 IL-23 inhibitors approved for psoriatic arthritis. We can see here on the right approval for the American and the European agency in 2020, the approval. And you can see here that Tremfya or guselkumab, along or in combination with methotrexate, is indicated for the treatment of active psoriatic arthritis in patients with an inadequate response or intolerance to DMARD therapy. But what's the rationale of blocking IL-23 in psoriatic arthritis? Well, we have a rationale coming from genetics, and we have rationale coming from animal models, and of course we have a rationale coming from clinical studies. First of all, we can see here results from GWAS studies, for genetic studies, and we can see here that genetic variants related to the IL-23, IL-17 axis, like for example, the SNPs in the receptor of IL-23, SNPs in the P40 subunit of IL-23, or even SNPs of STAT3, which is a transcription factor, very important in the IL-17-23 pathway. These SNPs are very well related with psoriatic arthritis, with psoriasis, and even with related diseases like IBD. So that's very important to take into account to start the development of a drug in patients with psoriatic arthritis. We have also evidence coming from animal models. This is a very famous model, mouse model of Sherlock, showing the presence of this T cell resident of dentasis in the mouse model. And we can see that this T cell have a very particular characteristics. It has this receptor for IL-23. So in the presence of IL-23 coming from the gut or coming from the enthesis, this cell is activated and can release IL-22, IL-17, even TNF, starting the inflammation, the bone proliferation, the bone loss, starting the disease, and only blocking IL-23, that will be the only way to resolve the inflammation in this mouse. We have works from our group in Barcelona showing the presence of these particular structures in the synovial stroma, in the synovial membrane. This ectopic lymphoneogenesis, this structure are composed of B cells in the center and T cell surrounding them. We don't know exactly what's the meaning of these structures in psoriatic arthritis. They are present as well in rheumatoid arthritis. We see that in rheumatoid arthritis, they are very related with the formation of autoantibodies like rheumatoid factor, APA autoantibodies, and they're very related with the presentation of antigens. They are very related with the maturation of B cells to plasmatic cell. But we don't know what's the meaning of these structures in psoriatic arthritis because we don't have any autoantibody in this disease. We know that these structures are very related to worse prognosis, to patients who need more biological therapies, who are more erosive, but we need more information. And in a later study of our group, we demonstrated that these patients with psoriatic arthritis and positive lymphoneogenesis have a different profile of cytokines with a higher expression of IL-23 in the synovial membrane. So we can say that blocking IL-23 would be a very good idea in psoriatic arthritis because of the evidence coming from the genetic studies and from animal models. So we have two ways of blocking IL-23. We have ustekinumab and we have guselkumab. We have to remember that we have to bear in mind that IL-23 cytokine is an heterodimer composed of two subunits, P40 and P19. Ustekinumab is blocking P40 and guselkumab is blocking P19. Which is the best way to block IL-23? Well, of course, we don't have head-to-head trials, which would be the best option to solve this question. But we can see here in direct comparisons regarding biomarkers, and we can see here, for example, on the right, and you can see that the CRP levels, comparing cellular levels of CRP between guselkumab in blue and ustekinumab in purple, and we can see that the reduction in cellular levels of CRP is very similar between them. But if we go on the left to cellular levels of IL-17A and F, we can see that the reduction in cellular levels of these two cytokines is very similar until week 4, but from week 4 and on until week 24, after 6 months of follow-up, we can see here that the reduction is deeper with guselkumab in comparison with ustekinumab reaching a plateau. So it seems that the blockade of IL-17 with guselkumab is deeper and better than using ustekinumab. And talking about clinical responses, talking about comparisons between discovered trials of guselkumab in green and summit trials of ustekinumab, we can see here the ACR20 response. And we can see here that the probability of ACR20 response is the same after 8 weeks with guselkumab and ustekinumab. But if we take a look after 6 months of follow-up or after 1 year of follow-up, we can see that the probability of reaching an ACR20 response is significantly higher for guselkumab in comparison with ustekinumab. Of course, we need results from head-to-head trials, but at least we have indirect evidence telling us that maybe it is a better option to use guselkumab to block IL-23 in comparison with ustekinumab. So now we are going to try to review the main clinical trials of guselkumab in psoriatic arthritis. We have 3 clinical trials, Discover 1, Discover 2, and Cosmos 1, with more than 1,200 patients. Here you can see the study designs of the Discover trials, Discover 2 and Discover 1. The Discover 2, which is very focused in bio-naive patients naive to anti-TNF therapy. The inclusion criteria, 5 swollen joint count or above, 5 tender joint count or above, and a CRP levels above 0.6. In case of Discover 1, they included bio-naive patients, but also 1/3 of them had previously taken 1 or 2 anti-TNF. So they were mixing, they're including bio-naive and bio-resistant patients to anti-TNF. The inclusion criteria, 3 or above swollen joint count and 3 tender joint count or above, and a CRP level above 0.3. We can see here the study designs, very similar between the 2 studies, 3 arms, 2 arms with guselkumab 100 every 4 weeks, guselkumab 100 every 8 weeks with an additional dose at week 4, and a placebo arm. The primary endpoint, ACR20 response at week 24. Here you can see the full baseline characteristics of the Discover 1 and Discover 2 trials. Of remark, the disease duration of psoriatic arthritis, we can see here the mean around 5, 6 years. So we are not talking about long-standing disease. They are not early disease, but not long-standing. That's something very important to take into account. The joint count, the number of swollen joints and the number of tender joints, around 11 and 20 respectively. So they are polyarticular pattern mainly in these clinical trials. CRP levels around 1 mg/dL. And when we take a look to the skin involvement, you can see here the body surface area, we can see that it was quite serious. So in fact, it was more serious than we usually see in clinical practice. We see body surface areas of around 18, 19% of the body surface. So that's something very, very important. And that's something very important to bear in mind when analyzing the results. And last but not the least, we can see here the use of methotrexate in around 60% of patients, which is something very similar numbers, very similar to previous studies with another biological therapies. Here we can see the results of primary endpoint, ACR20 response at week 24, and we can see significantly better results for both arms of guselkumab in comparison with placebo, 64% of them reaching ACR20 response versus 33% in placebo arm, with significant differences from week 4. In the Discover 1 trial, including patients resistant to anti-TNF, we can see that the results are very similar, and that's something of remark, because we see that the absolute numbers are very similar between bio-naive and in a mixed population with bio-naive and bio-resistant patients. So that's something very important that we have also seen in another trials with another options of biological therapies in psoriatic arthritis. And we can see here that significant differences from placebo were reached from week 8. Analyzing the results after 2 years of follow-up, we can see here that the kinetic of response is different from another options, is different from anti-TNF, is different from IL-17 inhibitors. We can see here the curve, the graph, and we can see that the maximal response is reached after 6 months and even after 1 year of follow-up. So we can see significant differences from placebo from the beginning, but we can see that the responses are better and better along the study. And that's something very important to take into account when analyzing the results. Even using a very conservative analysis of non-responding imputation, we can see that very high retention rate of patients with this drug reaching almost 75%, 76% of ACR20 response after 2 years of follow-up. And that's something very important to remark. And even the ACR50 response, very high, 55% after 2 years of follow-up, and ACR70 responses of 35% after 2 years of follow-up. So very good results and very good retention rate after 2 years. Regarding secondary outcomes, we talk about skin involvement. It was quite serious in general in this population, and we can see here the results, especially for guselkumab every other month, every 8 weeks. We can see here the results. We can see 45% of PASI 100 after 6 months, which is quite remarkably. And after 2 years of follow-up, we can see that the responses, the complete resolution of skin involvement was reached around by 53% of patients. So that's something very, very awesome. Talking about low disease activity, talking about remission, the concept that we have in psoriatic arthritis, very similar, very close to remission, is minimal disease activity. It's a concept maybe closer to low disease activity than remission, but it is very important. And we see that 25% of patients reach minimal disease activity after 6 months of follow-up, and 40% of them reach MDA after 2 years of follow-up. Regarding enthesitis and dactylitis, which are two very important domains in psoriatic arthritis, we can see that complete resolution of enthesitis was reached by 70% of patients with guselkumab every other month after 2 years of follow-up, and 83% of patients reach complete resolution of dactylitis after 2 years of follow-up. So again, very good results. Radiographic progression with this, which is a very important issue in psoriatic arthritis, we saw that despite most patients, including placebo patients, didn't have a significant structural damage progression, we saw that on the whole, taking into account the 2 doses of guselkumab, on the whole, significantly less structural damage progression was seen with both doses of guselkumab in comparison with placebo after 6 months of follow-up. And that's something very important to take into account, because right now, currently, in most trials, it is very, very difficult to demonstrate differences with placebo, because most patients, fortunately, don't progress. We don't know why. Maybe it is because of the early diagnosis, because it is for the use of methotrexate in the early stages of the disease, but most patients right now don't progress. And that's something that we see in psoriatic arthritis and even in rheumatoid arthritis. But when we talk with our patients in our daily clinical practice, we see that they are not interested in numbers of enthesitis, dactylitis, ACR, passive responses. They are interested about pain, they are interested about quality of life, they are interested about fatigue. And we can see here a significant improvement of quality of life in 64% of patients after 2 years of follow-up. And regarding physical component and mental component of FS36 scale, we can see a significant improvement after 2 years of follow-up. So improvement not only in joint responses, not only in passive responses, but also a significant improvement in quality of life and in patient-reported outcomes. The axial disease in psoriatic arthritis, which is a very hot topic right now. We don't really know what's axial disease in psoriatic arthritis. We don't have a proper definition like in axial spondyloarthritis. We don't have so many trials. We have one trial with secukinumab, the Maximize in psoriatic arthritis, and we will have in the future results for also guselkumab. For the moment, we have results from the sub-analysis of the discovered trials. They collected patients from discovered trials, patients with polyarticular pattern, but also with axial disease, according to the opinion of the clinician, and supported by the presence of sacroiliitis by MRI or X-ray. And we saw in this subgroup of patients, around 300 patients, we saw that with guselkumab, we had a significant improvement in the BASDAI scale, in the spinal pain scale, and in the modified BASDAI scale. So this is preliminary data showing that maybe guselkumab could be a very good option for axial disease in psoriatic arthritis in patients with this mixed pattern, polyarticular disease plus axial disease. Talking about safety, it is very important to try to maintain the same safety profile of ustekinumab, which is one of the main characteristics of this drug. According to the results of the different clinical trials, we can say that the safety profile is very similar to placebo. The most common reported adverse event were mild infections, upper respiratory tract infections, nasopharyngitis, and so on. Overall, 4% of guselkumab-treated patients had serious adverse events, but only 2% of them had to discontinue the drug because of the adverse event. No death, no tuberculosis cases, no opportunistic infections, no IBD cases were reported during the first year of follow-up. 2 malignancies were reported during the trial, and 1 major cardiovascular event was reported during the first year in guselkumab trials. After 2 years of follow-up, no news, no additional data. We can see a very good safety profile with a very low rate of serious infection, very low rate of serious adverse events. So of course we need information, we need data from clinical practice, we need data from observational studies and national registries, but for the moment we have very good data from the clinical trials. And last but not the least, I wanted to review the results of this COSMOS trial. This is the third trial of guselkumab in psoriatic arthritis, trying to focus not in bio-naive patients, but patients refractory to anti-TNF therapy. And that's something very important, especially in Europe, because here, as I previously said, it is very difficult not to put an anti-TNF as a first option in psoriatic arthritis, especially for biosimilars. So we need information, we need data of guselkumab in patients refractory to anti-TNF, and that's the aim of this trial, the COSMOS trial. You can see here the study design. In this case, we have two arms: guselkumab 100 every 8 weeks with an additional dose at week 4, and then placebo arm with a primary endpoint, ACR20 response at week 24, like you can see here. The main inclusion criteria: 3 swollen joint count or above, 3 tender joint count or above, and Caspar criteria had to be met with at least 6 months of follow-up since the diagnosis. 285 patients with psoriatic arthritis were collected, all of them with an adequate response or intolerance to 1 or 2 anti-TNF agents. Here, you can see the baseline characteristic of this population. Of remark, again, the disease duration was longer than discovered trials, around 8 years of follow-up. So that's something logical, because we are talking about a refractory population. Again, we can see here the joint count, the swollen joint count, and the tender joint count of 10 and 20, respectively. And that's something very similar to discovered trials. Again, CIP levels around 1 milligram deciliter. We can see here body surface area, skin involvements, again, very serious. So it wasn't mild disease, and that's something very important to take into account. And methotrexate use around 50–60% of patients, very similar to discovered trial and very similar to previous clinical trials with another option, with another biological therapies in psoriatic arthritis. Here on the bottom, you can see the reason for the discontinuation of anti-TNF therapy, most of them because of inefficacy. That's something important to take into account. You can see here the main results, the primary endpoint, ACR20 at week 24 after 6 months. And you can see here a significantly better response for guselkumab in comparison with placebo, 48% of them reaching ACR20 response against the 20% in placebo arm, and reaching almost 60% after 1 year of follow-up. You can see here in this graph that the probability of reaching a joint response was independent from the sex, was independent from the weight, independent from the presence of dactylitis or enthesitis. And you can see here that the guselkumab worked in the same level, independent from the use of methotrexate and independent from the reason for the anti-TNF discontinuation. It was the same for inadequate efficacy and the same for intolerance. That's something very, very important. Again, secondary outcomes, skin outcome, PASI 100 response, we can see after 6 months, 33% of them reaching complete resolution on skin involvement and increasing the response until 53% after 1 year of follow-up. And again, enthesitis resolution, dactylitis resolution, even with this conservative analysis, no responding imputation, we can see 40% of patients reaching resolution of enthesitis after 6 months and 55% reaching resolution of enthesitis after 1 year of follow-up. Numbers for dactylitis, 44% after 6 months and 67% of resolution of dactylitis after 1 year of follow-up. Again, very good numbers. And again, the safety profile, very similar to discovered trial, nothing new, no opportunistic infection, no active tuberculosis, no anaphylactic reactions, no cases of IBD, no death reported during the first year of follow-up. So again, it seems that the safety profile is very good for guselkumab, maybe in the same level of ustekinumab. So it is very important to take into account everything to put guselkumab in the right place in the algorithm of treatment of psoriatic arthritis. Of course, we need head-to-head trials in order to see which drug is better for psoriatic arthritis. For the moment, we have results from indirect comparisons using meta-analysis. And you can see here in this meta-analysis, which was recently published, that the joint responses are not different between guselkumab and other options. You can see that the joint responses are not different between anti-TNF and guselkumab, and between IL-17 inhibitors and ustekinumab, but we see that the joint responses are significantly better than apremilast, significantly better than abatacept, and even significantly better than ustekinumab 45 milligrams. So it seems that the joint responses are very similar between IL-17 inhibitors, anti-TNF, and IL-23 inhibitors, in this case, guselkumab. When we talk about the skin responses, the situation is different in this case because guselkumab is a very, very good drug for skin involvement. We can see here the results that all the spots on the right, meaning that guselkumab is significantly better than anti-TNF, than, of course, of apremilast, JAK inhibitors, abatacept, but also significantly better than secukinumab, which is another very good option for skin involvement. So it seems that efficacy is the same, talking about joint responses in comparison with anti-TNF or IL-17, but it is significantly better than these two options regarding skin responses. So in conclusions, we can say that guselkumab is the first anti-IL-23 P19 inhibitor approved for psoriatic arthritis, showing efficacy in all domains of the disease with a good safety profile. The skin efficacy is awesome, as I previously reported. And we don't know, but we are now running a sub-analysis of discovered trials, trying to see if the skin response is anticipating the joint response, which is something very, very important. Guselkumab has a very good efficacy in musculoskeletal domains. It seems that the response is better and faster than ustekinumab, but of course we need head-to-head trials. The safety profile is very similar to placebo and very similar to previously reported of guselkumab, but of course we need more information for clinical practice, we need information for observational studies, national registries, and so on. The retention rate was very high, which is reflecting a very good balance between joint and skin efficacy and showing a very good safety profile. Right now, there are clinical trials of guselkumab in IBD, in inflammatory bowel disease, and for the future, we have very good results for this disease, and for the future, I'm completely sure that we will have the indication not only in psoriasis, in psoriatic arthritis, but maybe also in inflammatory bowel disease, and that will be something very, very important for the drug to have several indications. The posology is very comfortable, and that's something important also for the patients, for young patients, for patients who like traveling. Only one injection every 8 weeks, every other month. So very, very good, very comfortable posology. On the other hand, also, of course, we need more experience in clinical practice. We need years of using guselkumab. We have negative results in ankylosing spondylitis of IL-23 inhibitors, but we can see in preliminary data in sub-analysis coming from discovered trials that it seems that maybe guselkumab could work for axial disease in psoriatic arthritis in the context of a polyarticular pattern. Right now, there are clinical trials ongoing of guselkumab in axial disease in psoriatic arthritis, and I'm completely sure that in 1-2 years we will have results for guselkumab in axial disease. So thank you very much for your attention. Now I will be happy to answer your questions. Thank you. Good afternoon, everyone. Thank you so much for the attention. I can see that there's a question from the chat, and trying to well, they are asking about one of the most important hot topics right now in psoriatic arthritis, which is the axial disease. Why does IL-23 inhibition doesn't help much with spondyloenthesitis, and what's my clinical experience in the management of psoriatic axial involvement with guselkumab and ustekinumab? That's a very controversial issue right now. In fact, we don't have a definitive answer. The truth is that we have negative results of IL-23, even with ustekinumab, negative results in clinical trials of ankylosing spondylitis. So maybe we shouldn't avoid the use of these drugs in the case of an isolated axial disease. So if we are talking about ankylosing spondylitis, even in the presence of psoriasis, if it is an ankylosing spondylitis, maybe it shouldn't be the first option. Maybe it would be better to use anti-TNF or IL-17 inhibitors. But in the context of mixed pattern, because we have to bear in mind that most patients with psoriatic arthritis have a mixed pattern with oligoarticular or maybe polyarticular pattern, but also with axial disease, with or without sacroiliitis by imaging. So in this context, I don't have a bad experience with either ustekinumab or guselkumab. Patients, for example, with a cervical pain plus a polyarticular pattern, it could be an option. Why it doesn't work? Why don't work ustekinumab and guselkumab in ankylosing spondylitis? We don't really know. There are several theories. They say that maybe at the beginning, IL-23 have a very important role in starting the inflammation, but once the inflammation is established, it is more important the IL-17 cytokine than IL-23. There are anatomical differences between peripheral entheses and axial entheses. Maybe the receptor of the cells are different. We have different T cells with the IL-23 inhibitors and another without IL-23 inhibitors, so they can produce IL-17 in a dependent way, or maybe in an independent way. So that's another very important theory right now. We don't really know. We have to wait for the clinical trials designed specifically to see the response of guselkumab in axial disease in psoriatic arthritis, because we don't have to assume that the axial disease is completely similar between ankylosing spondylitis and psoriatic arthritis. So the response is, if we have an isolated axial disease, maybe it could be a better option to use an anti-TNF or IL-17 inhibitors. But if we have a mixed pattern with polyarticular or oliarticular enthesitis plus an axial disease, it could be an option to use an IL-23 inhibitor or maybe ustekinumab. So we have a second question here in the chat, where we have reached regarding a study of guselkumab in lupus. I don't have the data. Unfortunately, I'm not an expert in lupus, but we have information. We have data from ustekinumab. I think that the indication is ongoing, but we don't have so much information about guselkumab. We could assume that, for example, in IBD, in inflammatory bowel disease, ustekinumab is indicated for Crohn's disease, I think, and there are trials ongoing with guselkumab, and it seems that the results are good, but we have to wait for the definitive results. And assuming that, we can assume that if ustekinumab can have a role in lupus, maybe guselkumab could have a role as well. But of course, we don't have definitive data for the moment, so we will have to wait. I don't know if we have more questions from the chat. Of course, we have in psoriatic arthritis a very busy pipeline, which are very good news for the patients, for psoriatic arthritis patients, and for us, because we have so many options. We are talking about chronic diseases, so it is very important to have options, because along the time we see that patients, especially with anti-TNF, the retention rate is not ideal, so it's very important to have new options. And guselkumab is a very good drug with efficacy across all the domains, and that's something very important. Maybe the main characteristics are that the skin efficacy is completely awesome. The safety profile, it seems very similar to ustekinumab, so maybe we are talking about the most safest biological therapy in psoriatic arthritis. And we can see that maybe the responses, ustekinumab, for example, the responses were not so fast. And this is different with guselkumab. In my clinical experience, I can see significant results from the second month. But we see that the efficacy is still increasing after 6 months or after 1 year. So that's a very good option. And according to the clinical trials, of course, we need information from observational studies, but it seems that the retention rate is quite high. So that's something very important for chronic patients. We will see in the future if it could be a very good option as after a failure to methotrexate in Europe. we have problems to justify an IL-23 after a failure to methotrexate because we have anti-TNF biosimilars, but in the context, for example, of patients with infection background or maybe with a breast-skin serious involvement, it could be an option after methotrexate.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory heel enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of heel enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
Good afternoon and welcome back. Our next symposium will be about Enbrel place in the landscape of spondyloarthritis. And we have our very well-known speaker, Dr. Khalid Al-Naqbi. Dr. Khalid is a consultant and good afternoon and welcome back. Our next very well-known speaker, Dr. Khalid Al-Naqbi. Dr. Khalid is a consultant and good afternoon and welcome back. Good afternoon, and sorry for this technical issue. So welcome back again. The next session will be about the Enbrel use and place and the landscape of spondyloarthritis. And our speaker is Dr. Khalid Al-Naqbi. He is a consultant and chief of rheumatology at Tawam Hospital. Dr. Khalid is a vice president of Emirates Medical Association. He graduated from UAE and he completed his training in rheumatology, internal medicine, as well as spondyloarthritis in Toronto. Dr. Khalid has so many publications in peer-reviewed and prestigious journals. He is a member of GRABA and a member of ASAS, which makes him the perfect speaker for our next session. Dr. Khalid, the mic is yours.
Good afternoon, everybody. My name is Dr. Khalid Al-Naqbi, consultant rheumatologist from the United Arab Emirates, clinical assistant professor at the UAE University. I'm going to talk to you today about Enbrel's place in the spondyloarthritis landscape. This is my disclaimer. So our agenda will be Enbrel and ankylosing spondylitis, joints and beyond, Enbrel and psoriatic arthritis, and case study. So ankylosing spondylitis, joints and beyond. This is just a reminder for our colleagues that ankylosing spondylitis is a form of arthritis that primarily affects the spine, although other joints can become involved, and usually it can cause the inflammation of the spinal joints, and in many of the patients actually they will have chronic severe and sometimes debilitating pain and discomfort that affects the quality of life. Comorbid conditions of ankylosing spondylitis are associated with more active disease, functional impairment, and deterioration in the quality of life. Therefore, the comorbidities should be detected and treated earlier in order to reduce their negative impact on disease outcome. This is just a fresh reminder to our colleagues who are listening. So I actually tried to put things in perspective by using scenarios. So there is a common scenario that may be asked by our colleagues is how fast can Enbrel work in ankylosing spondylitis patients? Is the efficacy sustainable? So let's talk about evidence from the literature. There is a rapid and sustained efficacy that the Enbrel provides a rapid and sustained efficacy in ankylosing spondylitis patients. And this study, you can see that patients actually were in a randomized controlled trial up to week 12, received Enbrel from the beginning, and some of them actually received the placebo. So after week 12, there was an open label study that 77% of them, of those patients who completed the first randomized controlled trial in the spine study at week 12, they were actually switched, those who were on placebo were switched to Enbrel, and those who were on Enbrel continued taking Enbrel. So 77% of those patients continued the study, and you can see up to week 24 weeks, there actually was most of the patients achieved the significant improvement in disease activity as evidenced by BASDAI. And the final conclusion of the study was not only patients had a significant short-term clinical benefit at week 12, but also there was evidence that BASDAI continued throughout from week 12 to week 24 in an open labeled study. So the other issue I wanted to emphasize here is that the response of Enbrel was also achieved in 64% of ankylosing spondylitis patients within 6 months. So that was evidenced by the BSRBR registry, which showed that nearly 2/3 of Enbrel patients achieved BASDAI 50 in 6 months. And you can see that actually compared to patients and the registry who received infliximab and adalimumab. So ankylosing spondylitis patients treated with Enbrel showed significant improvement in BASDAI scores. This is another slide that I want to show is actually, so we talked about week 12, week 24, and then 6 months. This is up to 3 years. So the data is still good. and patient sustained efficacy. And that was shown in a Czech national registry called ATRA registry that demonstrated that up to 70% of ankylosing spondylitis patients on Enbrel maintained BASDAI less than 4, which was the definition of inactive disease, up to year 3. Now, I have another question that can cross the minds of rheumatologists. My ankylosing spondylitis patient is worried about side effects of immunosuppressive drugs. What should I tell him or her about the Enbrel? So let's see. Now, this actually is a part of the study that actually showed that ankylosing spondylitis patients treated with Enbrel have a lower risk of infection. And you can see that compared to other TNF inhibitors like infliximab and adalimumab. So that is some kind of reassurance to our patients, and that was shown in the BioBadesser study, which was one of the registries actually that is well known in the literature. This is also showing the uveitis rates with Enbrel patients, and it simply shows that the bottom line that in this double-blind placebo-controlled trials, the uveitis rate with Enbrel was significantly lower than that of placebo. That's another aspect of infection, like tuberculosis reactivation, and that is clearly showing that in this purple bar, it showed patients with ankylosing spondylitis on infliximab. And you can see obviously that there is a high risk of reactivation compared to those with adalimumab. And then in Enbrel, it's very, very low. So the bottom line is that among patients with ankylosing spondylitis, the soluble receptor TNF inhibitor Enbrel is associated with a lower risk of TB infection compared to other TNF inhibitors, monoclonal antibodies. Comorbidities in patients with spondyloarthritis. This is again another refresher for you. Patients with AS have approximately double risk for cardiovascular disease. AS is a new independent cardiovascular risk as a factor, and that's why in my clinic I like to put actually all the risk factors for any autoimmune rheumatic disease. And ankylosing spondylitis is one of them. So I put the traditional risk factors like hypertension, diabetes, existing heart disease, CKD, and then the non-traditional and the newly identified like chronic autoimmune rheumatic disease, gout, sleep apnea, and other risk factors as well, like alcohol and smoking. The inflammatory process contributes significantly to the increased cardiovascular risk. Cardiovascular risk management is necessary and should focus on traditional cardiovascular risk factor modifications and type disease control. Now, here, talking about hyperlipidemia, so in a prospective 3-month cohort study of 92 ankylosing spondylitis patients, Enbrel was associated with an increase in total cholesterol, high-density HDL cholesterol, apolipoprotein A1 or ApoA1. And it is associated with a decrease in 2 potential markers of increased risk of cardiovascular events. The total cholesterol HDL, to HDL cholesterol ratio, there was a statistically significant decrease, but the statistically significant decrease was actually the ApoB to ApoA1 ratio. And you can see that in the table that was shown in the study, that there is actually at baseline, and then 1 month and 3 months, and then they classified it according to the factors like disease activity markers and acute phase reactions, proteins like CRP, high sensitivity CRP, ESR, serum amyloid A, BASDAI, from a scale 0 to 10. You can see that there is a consistent decrease from baseline after 1 month of use of Enbrel and after 3 months of use of Enbrel. And if you can look at the lipid levels here, the conclusion was that the concentrations of serum amyloid A, ESR, and CRP, and high sensitivity CRP were elevated at baseline but declined during treatment. And then conclusion number 2, that the degree of disease activity as assessed by the selected disease activity parameters significantly influenced lipid levels. And finally, during a 3-month follow-up period, decreasing levels of CRP, ESR, and serum amyloid A and BASDAI levels were significantly associated with improvement in lipid markers. Now, the recommendations for the treatment of patients with ankylosing spondylitis, so there is an ACR, SAA, or the Spondylitis Association of America, and the Spartan Spondyloarthritis Research and Treatment Network. Recommendations for the treatment of AS and non-radiographic axial SpA were it stated that the TNF inhibitors are recommended over secukinumab or izokizumab, both are IL-617 inhibitors, as the first biologic to be used. Secukinumab and izokizumab is recommended over the use of second TNF inhibitors in patients with primary non-response to the first TNF inhibitors. So you need to, according to this recommendation, you need to fail the TNF inhibitors. They're still powerful despite having newer mechanism like IL-17 inhibitors. Co-administration of low-dose methotrexate with TNF inhibitors is not recommended, nor is a strict treat-to-target strategy or discontinuation or tapering of biologics in patients with stable disease. This is one of the slides that I actually added today, is showing you that there is a sustained efficacy in real-life clinical practice of PASI 75 response rates in psoriasis. So when we are looking at psoriasis point of view in patients who are receiving Enbrel, you can see that beautifully that Enbrel patients who were still on treatment at 4 and 5 years maintained the PASI 75 score like 9 out of 9 and 5 out of 5 patients respectively. And that's reassuring data for us. Now, this is another slide, talk about Enbrel monotherapy delivers similar results to combination therapy with methotrexate for joint symptoms. And the left side of the slide showing you the SARC responders at 24 weeks. In Enbrel compared to Enbrel with methotrexate, they're almost similar. And in the right side of the slide, you can see the ACR 20, 50, and 70 responders at week 24. And you can see that patients with Enbrel, actually they have similar, almost similar actually response compared to Enbrel when you combine it with methotrexate. So the bottom line is that at 6 months, there was a similar proportion of ACR 20 and SARC responders in both the Enbrel and Enbrel with methotrexate treatment arms. The proportion of ACR 50 and ACR 70 responders was numerically greater in the Enbrel monotherapy group versus the Enbrel with monotherapy group. Enbrel and psoriatic arthritis now. Let's talk about the 3-year drug survival data from the NOR-DMARD registry of psoriatic arthritis patients receiving anti-TNF therapy. You can see from this study that actually the survival of the drug of Enbrel is actually significantly better than infliximab, and only with Enbrel group difference between monotherapy and combination was actually negligible compared to other TNF inhibitors. This is a sorry, it was a bit slide. Yeah. So this is a graph from one of the studies by colleagues Mies and et al. Showing that Enbrel halts the radiographic progression through 2 years in psoriatic arthritis patients when you use total sharp score. And that's important when you tell your patients about the importance of this drug and then keep taking it regularly so that there is evidence that it holds the radiographic progression. That's important. I'll show you my case study that actually signifies that. So there was a systematic review that Enbrel is not associated with clinically relevant immunogenicity compared to other TNF inhibitors, especially infliximab and adalimumab. So in summary, Enbrel may help your patients through significant improvement that starts as early as 2 weeks, proven efficacy in difficult to treat sites. I'm talking about psoriasis itself. Intermittent therapy proven efficacy in skin, joints, enthesitis and dactylitis, proven efficacy as monotherapy and no development of neutralizing antibodies. So let's talk about a case that I have of psoriatic arthritis. A 58-year-old woman with psoriasis diagnosed by a rheumatologist in December 2012 and then confirmed by dermatologists in May 2013. The main presentations in this woman was typical skin lesions that appear before musculoskeletal symptoms, which is most of the case, most of the times are like this. Bilateral plantar fasciitis, polyarthritis with knee stenovirus on MRI, dactylitis, enthesitis, and high ESR. Cousin has psoriasis, and she had negative HLA-B27, as most of our Arabic patients. She fulfilled the Caspar classification criteria. She has also features of fibromyalgia, which sometimes can complicate the picture when she complains of pain, and that comes intermittently. The drug history basically was methotrexate. She was started on oral methotrexate, 20 milligram weekly, obviously after some escalation. That the 20 milligrams started in December 2012 until September 2017. At that time, the methotrexate dose route was changed to subcutaneous, but the same dose as 20 milligram from March 2016 to September. I'm sorry, there was some kind of mixture. But bottom line, she was on 20 milligram weekly, orally, then switched to subcutaneously, and then she wanted to reduce the subcutaneous dose into 50 milligram, and then we resumed the dose after some kind of stopping. She stopped the medications because she was fed up on medications. Humira was given every 2 weeks from April 2013 to June 2016, and then Enbrel was actually given from 50 milligram subcut every week from August 2016 until the present time. So what did she have? This is the table that I like to put in when I see patients in my clinic, and this is the showing you the in March 2016, she had some disease activity, and you may be surprised that I'm using DAS28, but because the patient's insurance demands that I add the DAS28, so I have to comply, unfortunately. But I usually, in my notes, I show how many tender joints, and that time it was 2, swollen joints was 1, and enthesitis was 2, and I increased methotrexate to 20 milligram subcut at that time. And then May, I saw her, and she was doing better, but still she had 2 tender joints. And then I decided in August 2016 to start Enbrel, switch her from Humira into Enbrel. And over time, she actually improved significantly. And at one point in September 2017, she wanted to decrease the methotrexate because she was worried about side effects. So I decreased it from 20 milligram to 50 milligram subcut weekly. She kept doing fine, September 2017, March 2018, June 2018. And then she was doing great 2019. Maybe one time she had some low disease activity. And then until April 2021, she actually was off methotrexate in early 2021. And still she was in remission. But that at one point, she actually flared a little bit in August 2021 because she was off methotrexate, and the knee osteoarthritis that actually was supposed to get a knee replacement. The knee osteoarthritis flared at that time. That explains why she had some kind of disease activity. She really tried to stop the methotrexate, but she succeeded for a few months, and then the pain start to creep. And she wanted to continue the methotrexate at some points. Bottom line, I saw her last time in December 2021, and she was doing great on methotrexate and on Enbrel. So she's one of those patients who actually still continued taking Enbrel, but also with DMARDs on board. If you monitor the radiographic progression, I like to show in my clinic notes the cascade of events and looking at the radiographic changes. So July 2010, she had normal lumbosacral spine, but no peripheral joints were done. And then 2012, she had normal sacroiliac joints and mild OA bilaterally. 2014, she had a normal sacroiliac joints still. I kept doing it just to see if there is any progression, and also sometimes she complained of back pain. Hand x-rays in 2014 showed peri-articular osteopenia in the carpal joints and MCPs, but no erosions or OA or peri-osteitis. Knees had still mild OA bilaterally and no change in the feet x-rays. So basically the feet had some mild OA as well. In May 2016, she had mild degenerative disc disease and loss of cervical lordosis, no syndesmophytes, no facet joint disease. and moderate knees, but worsening of the knee OA on the right side. At that time, in August 2016, I started on Enbrel and then continued doing X-rays every 2 years. So in March 2018, there was no changes in X-rays of the neck, lumbosacral spine, and SI joints, and no erosions in the hands, and no changes of the knees, osteoarthritis, and no erosions on feet X-rays. February 2020, I mainly focus on the peripheral joints, so hands and knees and feet, there is no erosions. So I'm happy that at least I'm showing you that this patient has been on Enbrel since 2016. You're talking about 2017, 18, 19, 20, 21, and now we are in beginning of 22. So that's 5 years. And next time I plan to do a repeat of X-rays, and hopefully there will be no changes in her joints, actually, in terms of erosions or worsening of radiographic damage. So I explained to you in this brief presentation about Enbrel and where it stands in the ankylosing spondylitis world, and Enbrel and where it stands in the psoriatic arthritis world. And I showed you a case with psoriatic arthritis patients and who has been on Enbrel for 5 years and doing great, actually, on that. So with this, I actually like to thank you for your attendance, and please feel free to ask me questions, because we have plenty of time talking in the Q&A about any question relevant to Enbrel and spondyloarthritis. Thank you very much.
Thank you, Dr. Khalid, for the nice presentation, very nice summary about the Enbrel and the real-world data, and your case as well. We have one question from the audience that we will take first. So the question is, what shall we do if TNF inhibitors and IL-17 inhibitors were ineffective in axial spondyloarthritis, whether psoriatic or AS in particular? What would you do next in management?
So assuming this diagnosis is correct, and there is actually psoriatic arthritis, am I right? It's psoriatic, right?
Both. He asked about axial spondyloarthritis and ankylosing spondylitis as well, because in axial spondylitis, I think, the options are limited. And so if TNF fail, and as well as IL-17, we don't have a lot of options remaining. So what would you do in that scenario?
Well, the question is easy this time. If you fail everything, like TNF inhibitors and IL-17, then you're stuck with another one, the most recent one, which is the JAK inhibitors. So you have the Upadacitinib or the Tofacitinib, obviously. So Tofacitinib, as we all know, has received the latest approval recently, and that's a good option as well. Yeah, some of my colleagues have used it off-label in the past for ankylosing spondylitis. I have not, but I thought they told me that they found it working in some of their patients.
Interesting. And do you have patients, psoriatic arthritis with axial involvement on JAK inhibitors?
Not yet. They had back pain and psoriatic arthritis, which I could not prove that this is ankylosing, or let's say axial, because they didn't have HLA-B27 and they didn't have, I would say, the full description of inflammatory back pain, and they did not have MRI findings or X-ray of sacroiliitis. So they just had pain, and they told me they felt better after we started the JAK inhibitor. So, yeah.
Personally, I also don't have any patients with axial psoriatic arthritis on JAK inhibitors either. So, in regards to, you took us over some important concepts, especially the data that you showed about uveitis. Umbral by itself, I don't think it's approved for the use of uveitis personally. But there is some trend, the data that you showed that there is improvement with the uveitis. Can you tell us more about that?
So the data I showed actually just says that suggests that there is not a new onset of uveitis. Certainly, as you mentioned clearly, it is not the favorite drugs that we prescribe in patients with uveitis and ankylosing spondylitis. We prefer other drugs like other TNF inhibitors like adalimumab or infliximab. There is some suggestions in the literature that golimumab may work, and certolizumab as well. But for patients who did not have any uveitis, and those patients usually have those patients who are at risk of uveitis are those with HLA-B27 positive, and that's non-common in our culture, as you know. Arab patients and live in the Gulf, it's not that, it's rare to find HLA-B27 in general population, and also uncommon in the spondyloarthritis, unfortunately. I don't know whether this is fortunate or unfortunate, but we tend not to see these kind of patients, but it just tells you that you can start Enbrel in those patients with ankylosing spondylitis, because there is not increased new incidence of uveitis in those patients. That's all I can comment.
Yeah. Having said that, do you routinely test your patients like ankylosing spondylitis or non-radiographic axial SpA with HLA-B27 test or not?
All the time.
All right. So you have good data.
I have a lot of good data, but my problem is, again, it's if I have a positive HLA-B27 in AS patient, I usually have a party at the end of the day. Because it's very uncommon, you know, very, very uncommon.
Yeah, my patients, because I never see HLA-B27 positivity among our SpA patients. So we have another question from the audience. I think this question was explored in the previous session, but we can go through it again. So why IL-23 inhibitors not effective in axial spondyloarthritis?
Why IL-23? IL-23 Tremfya, I assume, like the other one. I would say there is some evidence that actually in psoriatic spondylitis that it works, but we don't give it. It's not approved by EMA or FDA, but indirect evidence shows that it might work in some of the patients. That's all I can tell you, but maybe unless we have stronger evidence in the future, then we'll use it at that time. I have never used it in this axial SpA patients for sure.
This is a very hot topic, and I think the data for AS have failed, but for axial psoriatic, as you've mentioned, we need more data with stronger evidence to support its use. I was reading about that, and it's kind of, we have IL-17 production, which, you know, induce enthesitis, whether it's in the peripheral joint or in the axial joint. IL-17 production, they assume, and this is a theory, it needs to be approved, that IL-17 productions in the peripheral joints need IL-23, and that's why when you block IL-23, you inhibit inflammation and enthesitis peripherally. But IL-17 production in the spine can be independent of IL-23. So you still have IL-17 there without IL-23 upregulated, and therefore you continue to have inflammation. And this is just a theory that I read in one of the articles, but it's very, very interesting questions, and of course we need more data, as Dr. Khalid.
I mean, I would use Enbrel in those patients who actually maybe elderly, that you want to stop the drug quickly. If there is a deterioration, then it takes a shorter time. compared to other biologics like adalimumab given every 2 weeks, or Symphony, or golimumab every month. So you have shorter acting, and it might be useful in patients who are maybe elderly, and you want to catch them when they get an infection or something like that.
So what's your opinion about escalating dosage? Like if you are stuck and you don't have an option, like you have ankylosing spondylitis and you've treated with all the options that you have approved so far, what about increasing dosage of, for example, Enbrel to weekly, twice a week, for example, or go to, like they use in psoriasis, or, you can, for example, increase the dosage of secukinumab or golimumab to 21 days instead of 1 month. Do you have patients like that?
No, I did not have patients actually. So in Enbrel, you can use it maybe twice a week. Trying to think actually if I don't know the dermatology dose, they use it twice a week actually.
Yeah.
So I've never used it in a patient 50 milligram twice a week. I never used it.
Yeah.
I consider it as a failure. But I also make sure that patients are taking their, if they are ankylosing or axial SpA, they're taking their NSAIDs, they're losing weight if they are obese. The literature supports that obesity is an obstacle for TNF inhibitors. Response or full response. That's why you make sure that you optimize the other things that may impede the effectiveness. Once you do, and smoking obviously. So once you do that, then khalas, if the patient fails, it fails. The patient fails. But we also have to make sure that other things are. It's not only for increasing responsiveness of the TNF inhibitor, but it's for overall health of the patient. Reducing, for example, cardiovascular risk assessment if they are diabetics, make sure they are well controlled, and exercise and diet, and stopping smoking, lipidemia, and all these things as well.
Yeah, especially with the high rate of association between arthritis and fibromyalgia, I think it's sometimes difficult. Do you tend to do MRIs to confirm the presence of sacroiliitis and people who have failed the biologic treatment? Just to assess whether this is fibromyalgia-related tender points or actually sacroiliitis.
Which MRI of what part?
Joint or spine.
So if there is a reason for me to believe that there is something in the spine, then I will do it. And if the patient complains of persistent back pain, and that back pain is inflammatory, then I will do it. I will do an X-ray to begin with, and we'll give, for example, make sure the patient is on non-pharmacologic therapy like the physiotherapy, occupational therapy, NSAIDs if needed, and then also the biologic Enbrel. But if they continuously have pain, I will still do at that time an MRI. Or repeat an MRI if it was done earlier for the same reason, to see if there is anything happening. And of course, I'll make sure that this is done properly under proper sequences like T1, T2 ester or T2 fat sat. Make sure that you do them properly, and then ask a good radiologist, or preferably musculoskeletal radiologist. It's very sad that I can tell you that not all radiologists can read the MRI properly. Some of them are just reading it just like that. I read it even better than them. So all these are factors to know exactly why the patient is failing. It will help a lot, actually.
Okay, so we have another question. So did you find any difference between biologics for patients with non-radiographic spondyloarthritis? So is there a difference between the biologics that you use for non-radiographic SpA?
Oh, from my experience, actually, so far, assuming the diagnosis is correct, right? No, nothing else, no fibromyalgia and other mimickers. I think that they are both patients with the axial, non-radiographic axial SpA and axial SpA, the classic one, ankylosing. They both have the same poor quality of life. They have both the same like functional limitations. Obviously, the classic one has more increase in CRP, To me, I found that, assuming there is no fibromyalgia, that many of them actually respond nicely with the TNF inhibitors in both groups, and also the JAK inhibitors. I have examples from both sides. It is the response in biological response in females may not tend to be the best compared to males. And I said maybe males, we like seeing males with the axial SpA because they have high CRP, maybe structural damage. So in a way, yes, we know the literature strongly supports those patients will respond more to biologics compared to the non-radiographic axial SpA, which is somehow common also in women, and that's why the FDA and the American system refused at the beginning to acknowledge the ASAS classification criteria, because their major problem was that you are going to include many patients with fibromyalgia. And they are not going to respond to expensive biologic drugs, and you're going to cause a disaster in the American system. So I can see their point with the over-diagnosis of the axial SpA in the United States based on these features, but you have to be careful actually to not to use the classification criteria for diagnosis. Make sure you know what this axial SpA is all about, and make sure that you have the classic, and you take a proper history and do physical exam, and then an MRI if needed with proper sequences, a good radiologist, and maybe you as a rheumatologist can be able to actually read it. And once you do that, then there is some chance that patients will respond, but there is also another chance that patient may not, especially if they are female.
Yeah, but then JAK inhibitors are not approved for non-radiographic SpA, right?
Yeah, so far.
We don't have any more questions. Is there anything else, Dr. Khalid, you want to add?
No, nothing actually. I hope people are enjoying this conference. I'm glad to be participating in this. I wish that I participated physically, but unfortunately, COVID again.
Yeah, COVID again.
It's hard.
But soon, inshallah, we will be able to meet in person. And thank you very much, Dr. Khalid, for this interesting discussion. And thanks to all the audience. We can end the session now, and we take a longer break.
Yeah, great, thanks.